right, hi, good morning. I think I'm gonna go ahead and get started in the hopes that we can finish a few minutes before the programming starts because our coffee is late, but I want folks to have time to get coffee before we, get into the heavy material of contextual data. So I'm Jennifer Elshire. I organize this workshop. I want to welcome all of you to the University of Southern California. You haven't been here before, it's a lovely campus. I encourage you to take walks when you have time. I arrange for this gorgeous weather, especially for you. So I'm one of the co-directors of the NIA-funded P30 Center on the Biodemography and Population Health. The other directors are Eileen Crimmins, who works more on the biomarkers side. So I work a lot on the contextual data side plus biomarkers. We also have two directors at UCLA, Teresa Seaman and Steve Cole. But I put together kind of a variety of presentations for you, consisting both of contextual data products that we produce here at USC, as well as some products that some of my friends are producing. Most of the content is for the health and retirement study, but you'll see that we actually produce these data products for many studies, not just the HRS. And the way that this is organized is I'm going to spend the morning just telling you a little bit more about the contextual data products. In the afternoon sessions, we have some scientific presentations where people are using different kinds of contextual data. You'll see that we've organized this into physical environment, so presentations on extreme temperatures and air pollution. Then there's two presentations on the social environment you'll see on your agenda. And there's a presentation on historical data, which I think is actually kind of one of the really new exciting directions that we have in terms of contextual data linkages. So I'm going to go ahead and get started on the first session, which is just overviewing the contextual data resource. I have a bunch of slides to get through, but I would encourage you, if you have questions along the way, to ask them. You're welcome to interrupt me by speaking. You can raise a hand. I very go with the flow. Because the presentation weaves through a lot of material, I think if you have a question in the moment, it's better to ask it when you have the question. Having said that, if you don't want to jump in, you can feel free to go on the Zoom and just put questions in the chat. And I just told the people on Zoom that they can, we can hear them very well. I did turn down the volume a little bit, actually turned it up, not realizing how this thing worked. I turned down the volume a little bit because it was a little loud. But certainly anyone on the Zoom can ask questions as well. I'm actually going to stay here behind the podium because these new smart monitors that we put in these classrooms no normal laser pointer work. So I'm just going to use the PowerPoint laser pointer. So I'll just be standing here for the duration. Okay, so just to give you some background, I don't actually think this is super important for this crowd, but there are some people here that are maybe relatively newer to things. Let's see, there's already a question in the chat. Is that? No, it's not. Okay, thank you. I just did a super quick and dirty exercise. Don't quote these numbers, but I basically went in to PubMed and I just searched on words like, it was a full search on neighborhood or environment and aging. I just wanted to get sort of a general sense of where we've been. So I started graduate school in 2003. Neighborhood research had been going on for a couple of decades. In the 90s, I actually started getting quite sophisticated with studies that were happening here in Los Angeles and Chicago and Boston. The MESA studies had started. So, now that we started to have a lot more data, we started to see more publications on neighborhoods. However, not that many people worked on neighborhoods of aging. I think there were some exceptions, like the Alameda County study, the work that Mary Hahn and George Kaplan were doing, and some of the other studies that focus a little more on older adults. So I do think that this growth in neighborhoods or environment plus aging is a little bit new, but you can see that there's been this kind of exponential growth that's been happening in this area. There are also some other things that people are interested in, including age-friendly communities. I'm just going to see if I can get rid of this thing. No? How do you minimize this?
There's on the more, put the optimized for video. That usually makes it. Or there's also a high panel. Yeah, the floating lead, yeah.
Thank you, Catherine. So there's a lot of interest in how to create age-friendly communities in countries around the world. And then most recently, there is this new focus on exposome or Alzheimer's disease exposome to address what they're calling overlooked environmental risks. So for several decades, there was a lot of emphasis on the Human Genome Project to try to map the human genome. And the thought was that it was going to explain for us a lot of the variability we see in the population in terms of different health outcomes. Turned out after all of that time, effort, and money, we only ever got to something like explaining, 23% or some pretty low percentage, actually. And now there has been a shift to understanding that it may not be genetic risks that are really conferring a lot of this population variability in health outcomes, but social, environmental exposures, or what is being referred to now as the exposome, which is this combination of how kind of environment throughout the life course interacts with biology to produce health outcomes. So not too long ago, NIA held a workshop on understanding the role of exposome in brain aging, Alzheimer's disease, and related dementias. And then that exposome funding announcement came out shortly thereafter. This is all just to say, I think that this is a major future direction, an area of interest, not just for NIA, but also NIHS, which is the Environment Health Institute at NIH, and that you're all on the right path, I think. I also want to point out that this is not new. There's long been a focus on context as a social determinant of health. And it's been recognized that the social and physical environments where people live have major impacts on their health and well-being throughout their life course. This is especially important for understanding some of the disparate health outcomes that we have not been very successful at reducing with a lot of research and a lot of effort. So racial ethnic minorities and people who have lower levels of education, less income, are more likely to live in places that are unsafe and hazardous. They're more likely to live in places that lack amenities and resources that promote healthy living. So these are major areas where we can actually make changes to improve lives. And this coincides well with the NIA Health Disparities Framework, which is very much built off of the NIMHD's Health Disparities Framework. And you'll see in their 4 kind of buckets of factors that they're interested in, environment is one of the 4. And so we do a lot of work on the geographical and political factors and socioeconomic factors. And you heard there are a few people here as well that work in healthcare. So how do we meet the current and future needs for contextual environmental data? It's actually quite difficult to harness these data and work with them. You need large teams, lots of funding to create pollution measures, for instance. For me, I always view this as a bit of a barrier for those of us who start first and foremost working with our surveys, with the populations we're interested in. We're maybe not environmental health scientists ourselves. We're not interested in spending our lives modeling exposures. We want to get those data and put them into our more social science-based models where we're focused on populations. But so now that we have so many of these large longitudinal studies that are sampling quite well a lot of different groups in the United States that have collected data on health and well-being over potentially decades, this provides really unique opportunities to advance the science around environmental impacts on health. However, we need to make sure that that environmental data are there. So I'm going to talk to you about these sort of contextual data challenges. What's available? How easy is it to use? Talk a little bit about linking to individual level data, although I'll go into that more tomorrow. I will say the entire point of the contextual data resource is just to make things easier for people to use, so we all don't have to recreate the wheel every time. It's designed to be a user-friendly sort of curated set of data that you can kind of pick out what you need and just hit the ground running. So we could invest a lot of time and money into collecting data, and some studies do that, and that's appropriate for those studies. For some of the rest of us who don't want to put that kind of time and effort into it, we need to leverage what's available. But the good news is every month, it seems like there's a new fantastic data set for us to use. So we're trying to centralize these data sets for users. So I started building the contextual data resource over 10 years ago. It was a slow process at first as we were kind of in uncharted territory. But since then, a lot of other data resources have come online as well. I think that there's a lot of opportunities for quickly accessing high quality data that you can append to your survey data, not just with the data resources that we produce, but with other data resources that are being produced by other groups as well. So as I said, the CDR is a collection of user-friendly data sets that are really designed to help researchers quickly grab data so that they can study the impact of place on health and well-being among older adults for whatever their research questions are. The CDR is currently, at this moment, available for use with the Health and Retirement Study, the National Health and Aging Trends Study, the Panel Study of Income Dynamics, and the Understanding America Study. And we're actually working with the Hispanic Epi study as well, and a couple of other studies to get them contextual data. But the idea has just been to create data sets that are linkable from public use spatial data to respondent level survey data. I will say, and I think every one of these situations, these are always restricted data products, meaning that you have to undergo some kind of special application process for each study. It needs to be approved before you can access the data. I'll talk more about that in the next session this morning. And almost all of these would be accessed via virtual data enclaves, with maybe some of the studies doing their own data linkages and producing data in a more specified way. But at least all of these big NIA studies here, they're all holding their restricted contextual data in virtual enclaves. So these data sets we also produce along with documentation. So the documentation explains exactly where we got the data from and all of the process transformations that the data underwent before arriving in their final form. The data are also produced with common geographic identifiers, so they can be quickly and easily linked with survey data. Obviously, the survey data needs to have geographic identifiers too. These data sets are available at multiple geographic levels. So we produce a lot of the data at the census tract level. For certain studies that we have sort of special arrangements with that we can get more finer grained spatial resolution, we produce buffer-based measures for those studies. And that's about the lowest we go. It's like a block or a buffer. But most of the data sets are available at the census tract level. Some data are only available at the county level. Some data make more sense at the metro area level. And then we have health utilization, healthcare access data that might be available in a completely different geography, like a hospital service area or a hospital referral region. You'll notice I didn't put state on here. We have very few data sets focused on states, but I'll tell you about a data source or a couple later in case you're interested in state level characteristics. So for those select surveys, as I said, we also create buffer and distance-based measures based on the household location of the respondent. I only do that for the health and retirement study. We're doing some of that for the Understanding America study, and we might be doing some of that for the Hispanic Epi study as well. Because these studies originated many decades ago, we have temporal coverage starting as early as we can. A lot of these data sets we have back to 1990 at least. We're actually extending some of these data sets even further back in time. When I first started putting together the contextual data resource, I did it specifically and exclusively for the health and retirement study, which started in 1992 or 1993 or 1998, depending on what cohort we're talking about. But studies like the HRS and several others are now capable of tracking people a little bit through time using residential history information, or studies like the PSID have always tracked people through time so long as they've been in the survey. So we're trying to extend some of these measures backward in time. We sort of bump up against the data limitation, which is why I have someone here to talk to you a little bit about potential data linkages with the historical census data, which goes all the way back to 1940. So most of our measures are created as like annual or semi-annual measures, depending on the source. We do this again for ease of use for users. However, someone may not be satisfied with an annualized measure. They might want something a little more detailed. They might want something that tells them something about the temporal variability of a measure throughout a year or a month. So we are developing more fine-grained temporal measures for some of the surveys that we work with. Those again require kind of specialized data linkages. So we're so far really only doing those with the HRS, the UAS and the Hispanic EPIs. Here's a list of the data products. I would not say this is an exhaustive list. We have quite a longer set of data, but just to give you a sense of what we have. So we've kind of, Callie helped me organize these into topic areas. So under socio-demographic environment, we do collect the census and ACS data. These are all of the years that we've processed so far. We did add this metro area CBSA geography this time around, but we always had it available at the tract, county, and state level. So this is the only database that we produce state level estimates because people often need that in order to even create metro or county measures. For the rest of them, you'll see they're almost all at the tract level with some at county and a few more at state. So under the air pollution, I want to note that again, we kind of pick up what we can where we can find it, and we process it to make it more user-friendly. So there was a data set that modeled NO2, but that data are only available from 2000 to 2010. Our more recent data are the PM 2.5 and ozone that we get from the EPA, which is available in this time frame. And there's another data source, which is PM 2.5 plus its components, which we make available at the census tract level. These little stars indicate that we're in the process of updating these data sets because there's newer data that's been produced. What's not on this list is that we're also processing data from what used to be called the NADA data, the air toxics assessment data. And so that has information on a lot of different chemical components in the air and emissions. And they also do some modeling of population health burden and great measures that are useful to researchers. One of our newer data sets that we're processing through various studies is weather data. So we've produced kind of a list of weather variables. You'll hear a little bit more about this in a presentation this afternoon. Weather is one of those data sets that you can actually get pretty far back historically because we've been monitoring it for so long. On the other hand, something like PM 2.5, the US only switched over the National Monitoring Network in around 1999-2000. And it was only starting around 2002 that a complete monitoring network was in place to produce comprehensive data. We have information on crimes from the FBI's Uniform Crime Reporting data set. Those are available at the county. Theoretically, you could try to get those at the city. We've tried this. It seems quite difficult. So for now, it's not a priority for us. We also grabbed these interesting food environment measures from the USDA. Which we make available at different geographic levels. In terms of the healthcare environment, we have the Dartmouth Atlas of Care data and the Area Health Resources file. They have some overlap and also some distinct components. And I'm going to go through all of these in a little bit more detail in a moment. And we also have measures of the built environment like walkability, noise, and we're putting together a couple of other data sets. I've been trying to get more of these multidimensional measures for folks who may not be aware that they exist. I think one of the challenges is figuring out all the contextual data that are actually out there. It's a lot at this point, and understanding the quality of these data as well. But we're working on this data to produce for the CDR. And we also have some noise data. This is one of the noise data sets. We have another more traffic-based noise data set as well.
Jennifer, for some of the data sets, like for example, for the crime that is at the county level, do you have a sense of whether the data comes from the whole country or is for certain regions? On one, and second, have there been any changes on county boundaries over that period of time and how that is handled?
Yeah, so county boundaries change. That's the work that we do. And I have another slide later that goes into more detail to answer your question.
Okay.
Are there any other questions up to now? Okay, most of these I'm going to go through in a little more detail.
Okay.
In just a minute. Okay, so this is my little diagram that Chow helped me put together on how we approach the exposome or the environment in our group. So we think of environment falling into these 4 buckets, just in terms of these data, which is the physical and built environment. So this is like road networks, streets, tree canopy. There's also the social environment. Those are things like poverty, crime, any kind of human-driven activity. We also work a lot in the chemical environment, mostly in terms of air quality, although we're looking at potential data sources to get at soil toxics as well. And then amenities and resource environment, which most of what we work on is the healthcare environment, but there are a few amenities as well. The importance of a data set like the contextual data resource is that we do try to get a lot of exposures over time. So pretty rarely grab a data set that's only available for 1 year. I don't find that to be particularly helpful because I think we really want to be thinking about exposure time, which I think of in 2 ways. And if you were at the Science of ADRD last week, excuse me for repeating myself, but we think about exposure both in terms of just kind of secular time, so how much can exposure accumulate over years and years and years, over decades. And so if you have 3 decades of temperature, 3 decades of poverty, 3 decades of air quality, you can really try to understand like what's the cumulative burden that different communities and individuals experience and how might that differentially impact their health. But I also think about exposure periods. And so I mentioned not a lot of those measures, as you saw, go really far back in time. Even the census, which does go back in time, I only use it from about the 1970s because prior to that, things like how we categorize race and ethnicity is totally different. And we also moved from enumeration districts to census tracts. It just becomes very difficult prior to about the 1970s. Although, like I said, there are now these efforts to do historical census data linkages, which are not without their challenges. But getting that kind of very early life exposure can be difficult for cohorts that are quite old now. We are doing pretty well at getting exposure in midlife, though, and you'll hear from people today who have both early life exposures data and midlife exposures data. And then a lot of us are measuring things kind of in older adulthood. But this is important when we think about our hypotheses and the sort of plausible biological mechanisms linking different environmental factors to health outcomes. There's no one story that's going to fit every exposure and every outcome scenario. But we do need to think about like, were there kind of critical periods throughout the life course where even where like a large short-term exposure could have had a long-term impact? Or could it have been a small kind of gradual accumulation over time that impacts health? So this is our website, which you have a little QR code in one of the materials in your folder. This website's under construction, so it's not super up to date, but as I said, you're all on an email list now. So as we update the website, you'll all get notifications when that's occurred. But this is where at least some of the data sets are held. On this website is where you'll find that really detailed documentation I was talking about that goes into a lot of the information about where we got the data from, how we processed it, and exactly what variables are in each data set. I'm always frustrated when I can't figure out like what's in a data set, so we have put everything into these PDFs that are available for all of these different data sets. That way you can see kind of very quickly what variables are available and what timeframes and at what geographic scales. Okay, so I'm just going to go through a couple of the data sets that we've developed so you can understand a little bit what we do and also what you might be able to do with some of these data sets. So the first one I want to talk about in social environment is the census data. For folks who don't know, for some of you very young people who started graduate school long after I did, when I started grad school, the only thing we had was the decennial census. That meant that we understood things about neighborhoods from data that were collected every 10 years. So if we were in, say, I don't know, like 1998, we would take the 2000 census and the 1990 census, and we would do a weighted interpolation to try to understand like an estimate of what characteristics might have been like in 1998, because no data were collected on the population in 1998. The point of the census is not to provide researchers with data, although increasingly we've made the argument that that is one of the major advantages of such an expensive activity. The actual official objective of the decennial census is to be a complete count, although we do undercount certain populations. And it's used as the official count of the United States. So you probably heard a lot about this at the 2020 census and all of the kind of controversies surrounding it. But this is essentially what the purpose of the census is for. So it's conducted once every 10 years. I think, the decision was made that even for funding allocation and policy purposes, that was not a frequent enough interval of data collection, particularly in a country whose population grows and changes so rapidly, even from one decade to the next. So that's why they launched the American Community Survey. So keep in mind, when you have the decennial census, you have really limited information. You can get complete counts. These are not estimates. There's no errors associated with it, but only for characteristics like age, sex, race, ethnicity, housing tenure, and the housing relationship. That's not super useful to researchers, so we use the American Community Survey. Prior to that, the census had a long form survey. That's what we used for some additional characteristics, but again, it was only asked every 10 years. Switching over to the ACS, the objective here is not to get a complete count. That's too expensive. Instead, it's a continuous survey that samples like 3 to 4 million residences a year. They do something like 300,000 a month or something. So it's not an official count, and more importantly, what you need to understand is that it is an estimate, and so the census actually does produce errors with these files. I've never put the error files in with these files because most people, including like the biggest expert in the country, don't actually know what to do about the errors in the count. But I can talk to you a little bit about what we're planning to put into the contextual data resource at some point. So the decennial census, very limited characteristics. ACS, much more detail, and it's basically what the long form census used to collect. If some of you don't even know what a long form census is, congratulations on being born in the 2000s or the late 1990s. So we primarily use the American Community Survey now, but it's important to understand what this survey is. So the ACS produces geographic estimates at 1 year, 3 year, and 5 year intervals. They've now moved just to the 1 and 5 year intervals. What this is showing you though is because it's a survey, it's a probability-based sample, they don't select the entirety of the units in any given year. So here's a subset of this table from the census website. You can see there's 3,222 counties currently, and the 1 year estimates, which can only be collected in areas, counties, whose population exceeds 65,000. They only end up with about 848 counties in 1 year, so about 26% of the total number of counties. Now, once you add those all up after 5 years, you've gotten all of the counties in the United States. And then the other important things to note from this table are that, for instance, you cannot get 1 year estimates for census tracts or for block groups. You can do it for places. So if you're working on a study where you need city level geography, you work with the places data. Not easy, but it's doable. But you can see this is even a lower percentage in terms of the overall number of cities in the United States. So census tracts and block groups are the data we primarily use in our local area estimates, and you can see that you have to use the 5 year estimates for these. And it's because no census tracts or block groups are going to meet this threshold of 65,000 or more. There are supplemental estimates that are used in populations of 20,000 more, but again, block groups and census tracts won't meet that population threshold. I didn't show you in the table the metropolitan statistical areas, but this information is here. So you can get 1 year estimates, but only if it's an MSA that has 50,000 people or more. So this is a caveat or an exception to the 65,000 plus rule, and you'll never get ACS data for blocks. So if you're doing an analysis at the block level, you really have to use what's available in the decennial census, which I showed you is essentially age, race, and ethnicity and gender. The other thing to keep in mind is depending on what year you want to use, there are some differences in what you will have available to you. So the ACS rolled out in 2006. So in 2006, for any areas that had a large enough population, they produced a 1 year estimate. They did the same thing in 2007. Now by 2008, they had both the 1 year and the 3 year estimates. And so that's why you see you have these 3 year estimates as well. The same thing for 2009. Starting in 2010, they provide both the 1 year and the 3 and 5 year estimates. Although, as I said, they've moved primarily to a 1 and a 5 year. This is like an old table from some congressional testimony that Bob Groves did a couple years ago. And this just kind of highlights again, for your sake, what's the difference between the 1 year and the 5 year ACS data. So the 1 year data get collected over the course of a year. They're available, but only for those geographies that have a large enough population. Whereas the 5 year data are collected over many years, and they can include geographies with fewer than 65,000 people. Thinking in terms of your research questions, if you're really interested in some kind of annual change that's happening, you'll want to use the 1 year estimates, obviously. And you should keep in mind that the 5 year estimates are more reliable because it's combining all of those samples, so it's lowering the error. But there is some overlap, so you're likely to get kind of a smoother distribution. And this is a figure, this is also from Bob's report. I'm sorry for the lack of clarity. I don't know why the figures look so fuzzy in his report. But you can see that if you were to use the 5 year estimates from the 2011 to 2015 ACS, as well as the 2012 to 2016, you have this like substantial overlap. So obviously these estimates are going to be very similar to each other. You'd have to move from the 2011 to 2015 ACS all the way to the 2016 to 2020 to get like really different estimates that have no overlap in the sampling. This may not matter for your research question, but it's something to think about because again, if you're really focused on some kind of like annual change, you're not going to get a very good picture of that from 5 year estimates because they're overlapping so much in their samples. Now, I mentioned that we don't provide the errors of the estimates, but I think that we want to, and we want to provide it with a handy guide. The only way that I have found particularly useful to use those is if you're studying a group that's a smaller size of the population. So maybe you're studying like older, really highly educated women because educational attainment was not that high in older cohorts of US adults. That's going to be a smaller sample. That means when they go into the census tracts, they're going to sample that person, but they're going to sample them with much more error than someone who's from a demographic group that's much better represented in the population. The one thing that we do sometimes is we check to see if it's a group or a census tract that has a really high error. What happens if we remove that census tract from our analysis data set? And what happens if we sort of impute different values based on the error bound? So those are some of the strategies that we use just to make sure that our results are not sensitive to some really small sample population demographics that are generating really large errors in the ACS estimates. Beyond that, people have done a lot of like modeling to try to figure out how to draw power from similar census tracts. I don't find it useful for the kind of research questions that we have. So we'll be working on a guide on that for folks. Having said that, no one else is really paying attention to errors around the ACS estimates. I don't think you necessarily have to be the first person who starts doing it. So this is a list of some of the population variables that we have and also some of the housing variables. Because we focus a lot on these aging surveys, we do try to grab these data as well for older adults. So those are the kind of cross tabulations. So some of these are the simple tables like age and sex, but we also try to cross tab them against older adults as well so that we're understanding not just the characteristics of the places where people live, but the characteristics specifically of the older adult population in those places as well. Any questions on census data? None of this is designed to be like a comprehensive course on any of these data sets, by the way. We have a lot of information on where people can go for additional reading. It's really just designed to let you know the different kinds of data sets that we have. So this is just a use case that we have. We're working on a project to try to estimate where populations are growing and temperatures are warming. And so this was using census data to look at growth in the 65 plus population over several decades, and you can see that the number of 65 plus folks in a census tract increased over time, as did the total variability of these populations as well. And you'll see a presentation tomorrow about how to map data like these and how to do these kind of graphing exercises. But this was just us trying to figure out where in the United States were populations getting older. And then we have other maps on where places were getting warmer. And this is some work that I did with a former PhD student, Catherine Perez Garcia, who's here today, where we actually linked these data to the health and retirement study because we wanted to know what the distribution of neighborhood poverty residents was in older adults by race and ethnicity. And so we were trying to understand what those distributions look like. And, you know, maybe not surprisingly, but even the lowest income white adults, not as many of them lived in a high poverty neighborhood as even the highest income Black adults in the health and retirement study. And this is partly explained by some regional and MSA differences, but not entirely. And this really reflects this really long, pernicious history of race residential segregation in the country. Okay, so we get the crime data from one of the data archives at ICPSR. It's a specific archive that's focused on justice. So all of these get collected by the FBI, and then they get aggregated and placed into ICPSR. So to Hiram's question earlier, like what are these geographies actually picking up on? Law enforcement agencies are sending their data. This is one of the reasons why we found it difficult to create city level data, because they're getting information from different municipalities. So like we have a City of Los Angeles Police Department. We also have an LA County Sheriff's Department. And so when you think about what is and isn't LA, that geography is a little hard to make sense of. What they actually end up doing is like all of those police departments would end up in LA County. The one issue is that there are some entities that are like not even in a county, they're in maybe an unincorporated or an incorporated area. In that case, they try to place them into a county. So we have like a complete county file, but it's for that reason that we haven't bothered to try to get at lower geography because it gets very complex. Having said that, if you're doing a study like just in LA or the city of Chicago, I think you can get street level crime data at that point. It's actually not too difficult. But all of the data sets that we produce are produced for the national context, and so we prioritize that above other kinds of data. But so what do we do for these data? The crime reports don't do any boundary changes for us. So we know that county boundaries change, which we get every 10 years from the census, a sense of how much those boundaries have changed. We actually do all of those boundary corrections. We produce all of the data in 2010 census geography. We're staying in 2010 census geography for the moment, which just means that so long as the data set that you're working with, the survey data, provide county boundaries or tract boundaries in 2010 geography, you can link to every year of the data that are in the contextual data resource. And most studies do. So like the HRS, per my advice back in the day, like 10 years ago, we produce geocoded addresses in 1990 boundaries, 2000 boundaries, 2010, now the 2020 boundaries are out. For our purposes to really streamline things, we put everything in the 2010 boundaries. So like for HRS, you can link anyone to the 2010 boundaries, even if they weren't interviewed in 2010. And so we do all of the county geography change corrections for you, so you don't have to employ like a graduate research assistant for a semester to figure out how to do that. We just did it for you. And so these are some maps that we created for different crime rate, county crime rates in 2014. So this is just showing like where a lot of robberies are happening, like the red areas versus blue areas. Although this is a geographic weighted map in a sense, right? If we population weighted it, this map would look very different, but no crime happens in these places because there are no people there to commit those crimes. And then you can see there's also like aggravated assault and like, for instance, homicide's a pretty low occurrence crime, despite what sometimes the popular media would have us believe. Homicides are way down in the United States and in almost all cities in the United States. And so that's why you see there's not a lot of homicide going on. And then there's also a total crime measure that's provided in the data set as well. Any questions on crime? Okay, so we take data also from the USDA Economic Research Service, this Food Environment Atlas. They actually do a lot of kind of under the hood work with micro level census data and business establishment data to figure out for each census tract how many like food options there are within a 10-minute driving radius, for instance. So they're making measures because they're government, they have access to these data, they're making measures that we could never make for ourselves. We can do things like that for our respondents, but we couldn't do it for the entire United States. As much as I really like the work that the USDA has done, once again, I have to reiterate, the federal government and a lot of these data producers are not producing the data for us. And so it's often not in a format that we can use. So these data come in like tabs in a spreadsheet, which is impossible to work with. So we have a whole process to extract all of those data. We kind of reformat them a little bit. We put them into Stata and SAS files that people can use along with documentation for it. So this data set doesn't go through a lot of processing, but it does take some extra steps. And we're going to be trying to create some longitudinal measures as well. So the kinds of variables are in the categories of food availability and food access, and this is what I was talking about. They'll do low access at either a 1 mile or a 10-mile radius. I actually think it's quite nice that they produce these differently for urban and rural areas. Buffer sizes should not be the same in places that are so different geographically and in terms of population density. They also did something kind of like what we were doing. They used the detailed tables from the census to produce these for older adults as well.
So, sorry, I missed how many years of the data is available?
So these data are produced kind of once every 5 years.
Okay.
So there's currently 3 years and a 4th just came out, which we have to now process.
Right, so those years are the one that will come 2024 and
It's
then.
like 2005, it's not exactly right, but like 2005, 2010, 2015-ish, something like that.
I see.
Yeah, and these are the kinds of things that don't change a lot in a couple of years. So like some things, you know, like weather, pollution, those things can change a lot, and crime could change a lot year over year. Some of these other characteristics don't change very quickly. Although now healthcare environments changing really quickly because suddenly a hospital closes or, you know, a unit closes in rural areas. Those changes didn't used to be occurring quite so rapidly. But at least something like the food environment doesn't change a lot in 5 years. But so the periodicity of this one's a little longer in between.
But the 2010, 2015, I would imagine that food availability might have changed because of the financial crisis.
Yeah,
In the 2010, so I would imagine a lot of tiny stores or people that might have closed.
that's true. Oh, and I should also say that, so we don't produce a full amenities file because I work a lot with Philippa Clark on the NANDA data repository, which I'll talk about in a few slides. If you want to know about how amenities are opening and closing on a year-to-year basis, NANDA has much better data for that. And so we use some of those data as well. And this is just a map we made at the county level, trying to understand if there was some kind of spatial signal in terms of the population with limited access to grocery stores.
Yeah, just a question in general. So if there's a county, they're missing a year of the information, do you impute them or do you just keep the raw data set?
For the contextual data resource, we typically aren't imputing. We impute all the time. We didn't do that initially because we wanted to give people kind of a clean version. They could do what they wanted with it. We're actually planning to create more like user-friendly files where everything is imputed, just to remove like even one more step so people don't have to do it. And then we'll do all of the work to check to see how much that imputation like fits in with the data well. But yeah, obviously there are a lot of options for people to do. You can just do kind of like a straight weighted interpolation, and you can also do like a more complicated multiple imputation and come up with multiple data sets. But you can see that county is missing, that county is missing. Okay, the biggest processing work for us was the Dartmouth Atlas. And that's because I think the Dartmouth Atlas data repository is extraordinary. It's very user-friendly, super cool data. If you're interested in healthcare environments and how changes in healthcare environments are impacting population health and older adults, this is an excellent data resource. Prior to like 2010, these were produced only, again, in these like multi-tabbed spreadsheets, which were quite difficult to work with. And then it took many other processing steps. Right around when we finished creating a longitudinal file, they started producing longitudinal files and data, but they didn't backdate it. Now, we've never gone back to see how we could kind of put these, the file we created from their data and the file they started producing. We never went back to see how we could put it together. I think we were sort of over it at the time. But they do now include these longitudinal files going forward from like 2010. We created them for the CDR. They're available to different data sets for years prior to that. And we're also working with other data as well, including the area health resource file, which is a county level file that has a lot of fine grained information on how the healthcare environment, access and utilization are changing over time. So this was like a map that a graduate student produced, trying to understand if there was spatial variability in HbA1c tests across the country. But we've produced these kinds of maps for a lot of different questions. You'll notice the geography looks super weird, and it's because these are these hospital referral regions that don't even respect state boundaries. So like if you're gonna work in the Dartmouth geography, you're in like a whole new world of geography, and you should keep that in mind. Whereas the area health resources file is all data aggregated to the county level. But Dartmouth does provide crosswalks with like ZTCA data or zip code data. So you could, if you don't, I mean, no one has their data in this geography. For the HRS, for instance, we had to overlay a geocoded layer on top of this boundary file so we could append the HSA and HRR geography. So if you wanted to do something like this, you would have to be able to do something similar for your study as well. They do have these crosswalks, but if you have the geocodes, it's just easier to do a spatial join. Okay, now onto the chemical environment. Again, I don't produce estimates of air pollution. It's not my main area of research. I don't have time for it. It's not my specialty. But the EPA does produce really nice estimates that I find to work quite well. So this comes from their website, where they use this multi-scale air quality model. They are basically taking data from ground monitoring stations and also a lot of other sources of data to produce these files. And they produce these files for both ozone and PM2.5 on a daily basis for all census tracts in the United States. So they've already done a lot of the work for us, but they haven't done all the work for us, because what are you going to do with daily data? So what we've done, also these files are massive. I mean, I have a new computer now, so maybe it would be fine. But my old computer would take a long time to just download the data, and it was really like a big job to open the data set as well. So what we do is we create these smaller files for people, and so we have annualized, well, we have monthly and also annualized estimates that are available from the Contextual data resource. We also, so this is a map. I guess these are census tracts. So this is showing PM 2.5 in 2006 and 2014. I always show this to people just to point out that the scale actually changed. So it went from a low of 3.91 to a high of 15 or more in 2006. And then by 2014, the low had gone down to 2.6 and the high was topping off at 12. That's because in 2006, this was the threshold the EPA had set for like, I don't know, above which was unhealthy, but it was like still unhealthy below the threshold. They try to go with like the most conservative strength assessment of the current science. So back then it was 15. I actually think this was kind of a political reason too, but they were very smart. But it basically shows things like we have a lot of air pollution in Southern California. That's not a surprise. I think people were always surprised to see this in the Central Valley because you think of that as rural areas. But agricultural based emissions are a serious problem. I noticed in the new map that this popped here and I thought like, wow, what's going on there? And it turns out that this is Spokane, Washington. That's had sort of a reindustrialization, which was probably good for the economy. And it looks like maybe not so good for their air quality. And then something we already knew is this sort of like Rust Belt area has a lot more emissions, and there are areas in the South that do as well. So by 2014, the EPA revised its standards to 12 micrograms per cubic meter or more being considered hazardous to human health. And 1 month ago, they revised it down now to 10. Those of us who study older adults always point out these standards are based on studies of all adults. And so they never paid particular attention to the fact that a level that might be like okay for someone our age could be potentially very hazardous for older adult health. This is another analysis I did with my former student, Catherine, who's here in the front row. And we were really shocked again to see that the lowest earning category of older white adults in the health and retirement study, they had about the same proportion who lived in a high pollution neighborhood as the highest earning Black adults in the health and retirement study, which is just some of the work that we've been doing on the kind of environmental inequities and injustice that persists in the country. Some of our newer data, like one of the newer data products is this one that comes from this atmospheric composition analysis group. So they're creating really similar measures. And I have to say, if we do correlations, they correlate at like 0.96 or something. They're not that different. This is still just PM 2.5. But what they've included are some of the components. And so actually some of this is might get at like the component of dust that you might find in agricultural areas versus say black carbon, which you're mostly going to find in urban areas. So we're trying to expand some of the holdings. So they do this for North America. They actually do it for all countries around the world, for those of you who do global work. These come in rasterized files at a 1x1 degree spatial resolution. So we actually take those raster files and we aggregate them up into census tract geography. Although if you know how to work with raster files, you can do this as well. But if you don't worry about it. We've got you covered. Okay, so for the physical built environment, as part of this NIH grant from NIA that I had when I started this, we created these measures of walkability in a neighborhood. We actually put these in the NANDA archive because I worked with someone who I used to work with as a graduate student at Michigan who works with Phillips. So Robert Melendez helped me make these measures, and he made some buffer-based measures for the HRS as well. So we just host this data set on the NANDA archive, so you can go and download it anytime you want. These are the kinds of walkability measures for those. Oh, it says requirement. These are the kind of walkability measures for those of you who are interested. I mean, if you're not into walkability, it's not a big deal. But in the documentation, I do reference some of the papers in case you wanted to learn more about what we do with different walkability measures. Another one of the new data products is this GridNet climate data. So this comes from a climatology lab run by a climatologist who does a lot of this modeling. So this is a data set of high spatial resolution, temperature, precipitation, there's like sun exposure and a couple other variables. These data files are probably the hardest that we have to work with because they come in these data cubes, if that makes sense. So they're layered data sets that are interrelated. You have to kind of unpack them. So we pull them out like a year at a time for a particular variable. I know this makes no sense to any of you if you don't think about like data in data space. But it's like a really genius way to pack a lot of data into a smaller data space. But it does mean that like unless you have those particular skills, you probably would have a hard time doing this. So we employ people who can use like Python code to extract these files for us, and then they run them all through R to create usable data sets. So these are data that you'll be hearing about in the afternoon session. We use this data in this project where we were looking at growth in the older adult US population against change in the expected number of heat weeks. We did a change in heat to make sure if we just did absolute values, we would just see like a really hot southwestern part of the United States. We wanted to see where are places getting older and where are they getting hotter. And we were particularly, unfortunately, we did the study and then the heat wave that hit the Pacific Northwest happened a few months later, and we saw some of the fallout from that in terms of older adult morbidity and mortality problems. But it really does kind of highlight areas that we may not think of, like these are the areas to focus on for climate change. Unless you combine your population data with your environmental data, you wouldn't know that, for instance, these two states up in the Pacific Northwest are going to have, a lot of trouble as climate change accelerates. There's also some places on the eastern seaboard that we're worried about as well. I'm going to save this. Okay, so those are all the data sets we've processed that are available to one or other of the studies that I mentioned. These are all of the things we're in process doing. We're trying to always make the data sets more user friendly. So first, I just produced the data. This was partly because I got a grant early in my career and then I realized I didn't actually have the data I needed. So at the time, my colleague Eileen said, why don't you just write a grant to like get more data? And I thought like, okay, and I did. And we started putting these data together. What I realized over time is that I'm increasingly a believer in democratization of data. I don't think that you should have been trained in spatial sciences and populations at the University of Michigan in order to, by the Chicago School of Urban Sociologists, in order to be able to use these kind of data. I also note that MDs and other healthcare professionals, nurses, et cetera, are increasingly interested in using contextual data, if not as a main focus, at least as a control variable, which I think is a good idea. So what we're trying to do is to create more user-friendly data sets. However, if some of you in here are really advanced users, we've got you covered as well. We're trying to make data sets that you won't have to spend so much time on yourself. You can just kind of grab them and go. Because of course, once you have the data, you're gonna have to figure out how to model them, and that's gonna be a whole other problem that you'll have. So we're trying to grab additional data sets that are compilations of several measures. I'm gonna show you this EPA Environmental Quality Index. There's a couple more that I've identified recently. We're also putting together these medical shortage areas or medically underserved areas. I think this is like critical at this point because we're seeing a growing trend in the country where more areas are becoming increasingly less served. In terms of healthcare resources and amenities. We're trying to create summary indices for high dimensional data sets. So the census data, there's just a lot. There's a lot of variables. It's over a lot of time frames. So we're going to try to create some summary indices that reflect, to start with, neighborhood socioeconomic status or deprivation. We'll also create some measures around age composition, race ethnic composition. We have a measure that we created to try to understand MSAs where population growth is outpacing housing growth, because that's an important thing for thinking about housing transitions. So we're in the process of making some of these measures, and tomorrow you'll hear about some of the work we're doing on the neighborhood SES measures. We also want to create some longitudinal measures over time for folks so that you don't have to do it yourself, just so that you get a sense of how neighborhoods are changing over time. I told you that we've provided monthly and annualized air pollution measures, but some people actually might want finer spatial scale. And when you average over, you take a monthly average or a seasonal or a yearly average, you're going to smooth over some of the air quality spikes that we see in a lot of parts of the country. So, and this is also a problem as well for air temperature spikes. So we're creating more spatially refined measures, although these are going to be linked to surveys in very specific ways, so they won't be available to just anyone. They're going to have to be linked to the survey most likely. Because at the same time, we're going to be creating these more temporally refined measures. So we've been linking daily pollution and temperature measures to the health and retirement study, and we'll be doing it for the Understanding America study and the Hispanic EPI study as well. Those temporally refined measures are not currently available for the HRS, but we plan to make them available like by the end of the year. So all of you all will have time as well. We're just continuing to kind of play with them, try to do some analyses with them, and assure ourselves that what we're producing for all of you is very user-friendly and high quality. But here's just a quick example of that EPA Environmental Quality Index. The problem that we have when we study the environment and the direction we should be moving in is this idea of the total environment framework that the EPA talks about a lot. NIH is now calling it exposome. These things to me all sound like the same thing. But this is an index that accounts for chemical, natural, built, and socioeconomic, sociodemographic environments. It's currently available at the county level for 2 years, so it meets my criteria that there has to be at least 2 years of time points. And you can see all of the different characteristics that they put into their index. What we're going to try to do, which we haven't started this work yet, is to see if we can create a similar index at a tract level and maybe with more refined temporal availability. Okay, so I told you, we don't do anything on states, but I do want to acknowledge a colleague of mine at Syracuse who's put together a state policy and politics database. If you're interested in states, if you're interested in state policies, this is a very comprehensive database. I don't work on states and I try to stay in my lane in general. So the contextual data resource will never have a particular focus on states. If you're interested in states, though, there are a lot of resources on it. So this is another resource from the network that I run in part with Jennifer Montez, who produced that state database as well as Bob Hummer and Sarah Burgard at Chapel Hill in Michigan, respectively. Margarita helps me put together this nifty tool that's on our network website where you can actually search a topic or a geography and it'll return all of these different options. So it'll tell you the kind of data that you might be able to get at, say, the state level. So we don't take state on explicitly as a priority in the contextual data resource, but I think that there are a lot of other resources out there on state level data. And you'll have access to all these slides, so you'll have all of the web links as well. Okay, I just want to take a few minutes to talk quickly about the data sets that we have linked the CDR to. So like I said, we started with the health and retirement study. These are the data sets that are currently on the website, as well as the time periods and geographic level. They usually say like version 1 or version 2 because we update them every couple of years, and we always make it clear in the documentation if something changed in an update, and also, you know, that it's version 2 for a reason. Maybe we just updated the data. Sometimes we make other changes to the data sets as well. We've produced data for the Understanding America study, and these are some of the data sets that are available with those data. I'm going to talk to you about how to access all of these in the next session. UAS has sort of a smaller set of data at the moment. We're being a little more selective in what's being released for the Understanding America study. And both HRS and UAS, we have special agreements to create some of those buffer-based measures. So we're working on those as well, but they take a little bit longer. But we provided the air pollution data. I actually think they'll probably get the updated data very quickly because they have a high need for this updated pollution data. And obviously we have to update the walkability data now that we have the 2020 Tiger Line files from the census. We've also partnered with the P30 Center of Michigan, MICTA, the Michigan Center on Demography of Aging, created something called the GLR, the Geographic Linkages Repository. So we've deposited our data there, that state policy database is there, the NANDA data are there as well. And that means that in addition to linking with HRS, you can actually link all of these data with the NHATS or with the PSID. I just want to make one last point before I wrap up, a tiny bit late, but that's okay, we can run into the next session. I do think there's a lot of opportunities around historical data on the life course, and I think if we're going to talk about the exposome, we have to be talking about the life course, because the exposome is the life course of social, economic, and environmental exposures. So where individuals were, the kind of exposures they had from early to middle life could really help us understand exposure. We've done some work in our own group around lead, for instance, that's made it maybe kind of clear to us that older adults' current exposure to lead may not be as important as their early life exposure to lead. And that has to do, again, with those biological mechanisms that we think realistically help us understand how environmental factors really get under the skin and how much that varies across different exposures. And I talked to you about cumulative exposure versus critical periods. We can do this from midlife to older adults. With some of our data sets, we might have like early adulthood to older adulthood. Very few of these data sets do we have at early life. Even if we have the people measured at early life, we may not have the exposures measured, or they might not be measured very well. But of course, with the new cohorts of older adults that are starting in these studies, which always seemed a lot older to me than when I started graduate school, and now I'm approaching some of these cohort age eligibility cutoffs. But we are now going to have people who were born in the 60s and 70s, and we can link an awful lot of environmental data with their entire lifetimes now. I'm not talking about this today, but I think it could be the topic of a future workshop. Because these studies have followed people over such a long period of time, and the studies I've mentioned to you have such large sample sizes, in addition to other studies like the Regards cohort, which is another huge sample size. We have the opportunity to leverage this artifact of the data, which I think helps with causal modeling as well, to really understand what's the impact of people who stay in places that might change around them or not, and what's the impact of people who move to different places. Although I call it moving to opportunity, because a lot of people have shown that when folks move from one neighborhood to the other, they actually just kind of trade the same thing for the same thing. So the idea that someone moves is going to like help us leverage variability is not necessarily the case, because what I have found is they move to essentially the same environment. And so in terms of trying to leverage that for like a good causal model, it's not as promising as we had maybe hoped. But again, we have many more people moving, new cohorts. new parts of the country and very large sample sizes, I do think this is a direction we should be going in. The biggest issue we always have is that we have something called baseline, which is the start of the study, but not the start of the person's lifetime of exposures. We tend to only know how long, where people have lived while they've been in the study, and where they were before that could be a total black box. We might know where people were if they've lived in the same home for decades, but if they moved at some point prior to their baseline and entry into the study, we just don't know where they are. And so for a lot of our surveys of aging, early and midlife, context is missing. However, studies like the health and retirement study have been trying to collect residential histories. A lot of other surveys already have residential histories, and many others we're working on trying to get those histories collected as well. So this is a real opportunity for us. I think these are great sort of like ideas for future projects and future grant proposals for people to think about. If you take like the health and retirement study cohorts, for instance, this is showing like the different cohorts. So here's the early baby boomer cohort. You can see like in 1970s, which I said I would work with census data back to the 1970s. We have some pollutant data and temperature data back to the 1970s. We could pick these people up in their 20s to 30s. We'll know what's going on with them until they start their baseline interview, and then we follow them through older ages. The mid-baby boomer cohorts, we can pick up in their 20s. The later baby boomers, we can pick up from adolescence. This is the newest cohort that was enrolled for the HRS, the Gen X. We would know basically everything about their lives starting from 1970. And then HRS will enroll a new cohort in just a few years, and we will have essentially their early life to later life exposures, or at least the potential for that. So these aging surveys, we are starting, they're starting to age into when we have good quality historical data. So we'll at least know something from like midlife or maybe early adulthood and eventually early life. So it's this Gen X cohort will have information since birth. I still think we should link for the older cohorts as much as we can. We'll just likely have less coverage of their early life. But you'll hear some presentations today where people have actually linked information from early life. Okay, I finally just want to acknowledge this work's been done with an incredible amount of support from the National Institute on Aging, and an incredible amount of support from graduate students and postdocs. So we do provide access to some of these other studies, but I do want to point out that I always prioritize NIA-funded longitudinal studies of aging. So we won't link these data to just any study. That's partly because of our obligations to our funders, and also because all of these linkages actually do take my team some time and dedicated effort. And so we have to prioritize, and we've decided because this is a resource made for longitudinal studies of aging, we will prioritize those studies. But for instance, when we talked with the folks from the Hispanic FEs, that's like a perfect example of a study that we think should have linked data. So we'll be working with them on that. Okay, so first I'm going to talk to you about how to get access to the HRS CDR, which I think was the question that we had from earlier. So hopefully I answer your question, but if not, let me know. So the HRS actually collects data that have been produced from users to put in their enclave for everyone. We're all under new data management and sharing requirements from NIA. HRS as a U project means we are definitely under this mandate, and so we're actually going to be expanding the data products that are made available to users through the enclave. Just so you know, for your own future information, if you plan to use the HRS and link to data that are not currently available in the enclave, you will have to work with the HRS to put your data in the enclave. And that data deposit might happen quite quickly. So if you don't want to do it, you should not think about using the HRS, because there will, going forward, be no other choice than to make your data available. And this is because of strong mandates from NIA on data sharing. So any data contributor can create a contextual data resource. You saw that I've created resources around things like air pollution in the census. Someone else created a data set on state policies. Those have all been put into the HRS enclave that anyone who has an approved enclave account can access. What HRS does, though, is not sort of like a free-for-all, like anyone can just kind of wing some data in there. It's important that it's well-documented and high-quality data. So the HRS works with the contributors to make sure that we have consistent naming conventions, that things are linkable, because the user is going to link these data sets unless they've been linked to individuals in the creation of the measure, for instance, in distance and buffer-based measures. And it's really important that we have complete documentation, so we create this enhanced user experience. So the data actually get put into HRS's space on the virtual data infrastructure at ISR at the University of Michigan. This VDI, this virtual enclave infrastructure is maintained by MICTA, which also has that geographic linkage repository. So any HRS user can access all of those data with an approved restricted data application. And I'm gonna take you through some of that. But keep in mind, if there's something in the HRS enclave that you want to use, then you can use that. If you notice that there's some data that you're interested in using that's not in there, you can always bring your own data into the enclave as well. So you're not limited to what's in the enclave. Okay, so how to access the CDR. Through HRS, you'll find it in this restricted data available products. I'm going to show you what that looks like. But first, so if you went to the web page, this is what you would see. So there's that 1940s census data. That group is also hoping to do a 1950 census linkage. That's under census data. We have all the HRS contextual data. Well, it says contextual data resource series, but you'll see that it actually includes data products that I don't actually produce, but they're part of the HRS contextual data resource series. So these were the COVID-19 state policies. A group at Brown does the long-term care focus database, and then the rest of these are different products that I've produced over the years for HRS. If you click on one of these, this is typically what you'll see for the data products. Some kind of standardized information about who the data products can be linked to, what the release date is. And I always provide user guides and variable documentation, and we're requiring that from others as well. Okay, so how do you access the data? I'm going to show you this in order to just make one point. There are technically or have been two ways to access the data: the virtual desktop infrastructure, that's the enclave, and traditional licensing. I'm telling you this today so that you know that you do not have the option of traditional licensing. HRS has been phasing that out, and so really you're going to have to do all of your work on the enclave. There are very few traditional licenses remaining, and they're for very specific purposes. So like I have a traditional license because I do data processing for HRS. But for the rest of you, you'll want to be applying for the VDI. I tell you this so that you don't waste your time trying to apply for a traditional license. If you think you might want a traditional license, which means that you actually get the data from HRS and you hold it in a secure computing environment. So we have a cold room here on the second floor where we have our data. I would talk to HRS first to see if you have even the option of a traditional license. But for the most part, you're going to be getting enclave access. Okay, so they provide a lot of information about how to apply for the data. This is actually old website stuff, so I'm going to show you what the new web pages look like, but I still thought it was kind of helpful to see. You're going to have to provide things like a short research proposal. This is not an onerous activity. You can basically just write whatever you need. You do need to explain what HRS restricted data you're going to be using and how it fits into your project, and they do actually review this. And then you need all the information for everyone on your study team. I want to point this out because I think that this has been a problem in the past. Sometimes people get confused because HRS produces this two versions that say cross-wave geographic information. I think sometimes people accidentally select the state. If you do that, then you don't get the tracked identifiers. You only get a state file. So it'll look like you don't actually have specific geographic units available to you, but it's because it's in this file that says detail. Now that's a little confusing, I think, because how are you supposed to know that the tracks are in the detail file? Maybe we should change the name. If you click this box, either one of these, I think you actually automatically do get access to the partitioned space in the enclave that has all of the contextual data products. So you don't have to select CDR products. As soon as you select geography, you get access to these products anyway. They require these data security plans for the enclave. So just because you'll be in the enclave doesn't mean you can have your computer wherever you want it. You actually still have to provide very specific plans about how you are going to protect the confidentiality and security of the HRS respondent data. So HRS is quite happy to let users use the data responsibly, and we want to promote that use. But I will say every once in a while, like I went to a conference last year and someone was showing locations of HRS respondents. And to be honest, I don't even know how they got that information out of the enclave. Did they have a traditional license? But it was a little shocking to me because you can never, ever, ever show people where HRS respondents are or even where they are not. So all of this is explained in the HRS documentation, but this is again just to impress upon you that we're given sort of the privilege of working with these data, but those privileges can be revoked for all of us if we violate the data user agreement, which is designed to protect respondent confidentiality. So this is the actual HRS webpage. If you have an HRS account, you have access to all of the public data. Let's say later today, you hear some of these epigenetics presentations, you get really interested and you want to see like what's going on with DNA methylation data. That's not in the public files, that's in the sensitive files. So that's where a lot of the sensitive health data are kept. That one requires a special application, but it is not nearly as time intensive as the restricted data application. You apply for sensitive data, you get it usually like within a week or something. The restricted data application can take longer, and that's because they only review these at certain intervals throughout the year. Some people, I think, have really experienced a lot of delays in getting access to the restricted data. Sometimes that's a delay on HRS's part. I think from what I've heard from people, most of the time it's an application that was not done correctly. So I really would suggest if you're going to apply for restricted data that you read every document they have on how you should say you're going to use the data. Make sure the application that you put in it matches as closely to what they say you should do as possible. Anytime you deviate, it's going to undergo a separate level of review, and almost certainly they're going to kick it back to you and tell you to fix it. So I think like if they tell you that you need to have a monitor that doesn't face your doorway and you're like, but I'm in an office where my monitor faces my doorway, find a way to turn your monitor around, because this is what's going to delay your application. And HRS, these actually are not exactly HRS protocols. These are the ISR protocols. So these will be the same for any study in MICTA, like the NHATs or PSID. These are designed to maximize data protections. And you're almost never going to get around these data protections because these are designed to protect the HRS respondents. So that's one tip that I have for you.
Jennifer? We have a question from the chat Maria asking what's included in the HRS epigenetic data.
On the website?
I don't know what epigenetic data is up there yet.
It's just the clocks.
Oh, the clocks. Yeah, so Maria, later today, there'll be 2 presentations using the different clocks that have been developed over the past few years. But eventually there'll be some other measures put up there. And actually, if you want access to the DNA methylation data, that's a different restricted data product. That's the genetics data. And you would have to get that actually might be one of the few products that you could get a traditional license for because they can't. Genetics data are so high dimensional that they're not held on the server.
It's on NIGADs now.
It's on NIAGADs.
I was about to say it was on NIGAD.
Okay.
So, but some of the traditional licenses are grandfathered genetics people. So the traditional license, there's like people who have the Medicare data, people with the genetics data, the contextual data. But new applicants, I think, will be pushed into the enclave. So like a new genetics application will go into using NIAGADs.
2 questions. to gain access to limited access or restricted data, does our project needs to be funded? Or can it be a project and can be, the second question, can we have access to the enclave? Will we have access to everything or something specific? Like if we are looking for linkages, we only get the linkages, but not CMS HRS data.
So it used to be the case that because we didn't used to have an enclave. When I started making the contextual data, the only option was the traditional license, and you had to have a major grant to sort of put up as like collateral that they could use to like give you a little bit of a smack if you violated your data use agreement. That was their only stick, essentially. Around the time when I started working on the contextual data, ISR was developing the virtual desktop infrastructure for MICTA, which I thought was great because I always thought it was such a high bar for a junior investigator to have a major source of grant funding to get access to the data. So this was a big accomplishment for HRS, and then a bunch of other studies followed quickly thereafter. So in order to get access to the enclave, you don't have to have a grant. But they have stronger controls on the enclave. So if you were to convince HRS to get access to a traditional license, you probably would still have to have a grant. This is not really the topic for today, but in my other hat I wear, where I work with the contextual data linkages with HRS, people who want to do linkages like at the address level can do it. There's a separate enclave that they can do that with. So like Sarah Adar has done that at Michigan, and Rob Warren did that for the 1940 census linkage, which required knowing like the person's name and other things to match them. So HRS is trying to encourage these kinds of data linkages, but they monitor them. People could get like special kind of privileges, but it's in a highly monitored enclave environment where they still have sort of a wall separating them from they never get the respondent IDs at that point. The linkage gets done by HRS, and very few people are ever allowed to visually lay eyes on anything resembling a respondent location. So, but they've piloted this with 2 different investigators, and it's worked out well. And so others can propose that and get a letter of support from myself or from David to do that kind of thing as well. So there's different levels of access. The other question is, what products can you get access to? So when you do your form, you can like click on everything. You could say like, I want the National Death Index. I actually don't know if that's on there at this point. I want the detailed birth dates. I want the occupation codes. But every product that you click that you want to have access to, you have to justify in your research plan. So like in our group, we were getting the detailed race ethnicity information, which is not available in the public files, because we had people who were interested in understanding variation in Latino ethnicity. So we had access to that data, for instance. We had someone who was working on some occupational projects, so we got access to that data. And then once those people left, we weren't necessarily requesting those data files anymore. So you can select as many data files as you want, but you have to justify it. The question about whether or not you can do other linkages. So you can ask so the CMS data linkage sort of goes through a different system, and it's also held on a different server, which has not always been easy for people to get access to. They've migrated, but I think that people should be getting access at this point. There is like a little table that explains like what you can and can't link. So like you cannot link social security data to the geographic data. Like there's just certain like kind of potentially risky linkages that could happen. So you have to check the HRS website to see if there's any advice or guidance on whether or not you can make certain linkages. All right, but so you'll see here it says if you want access, you start here unless you need CMS or Medicare data, and then you have to go through a different link. And then there's this other kind of access, which I just don't think is going to apply for most people in here. Like I said, I don't work in the enclave, but even after you get access, you do have to have some kind of reporting requirements. You may need to modify your application to add people or take people off once they've left. You should take them off your application. And then if you're working in the enclave, all of your work has to go through disclosure review. That's where they check to make sure that nothing you've done might be at risk of disclosure, which is kind of the biggest priority that the enclave has at this point, is to prevent disclosure from happening. As I told you with my story, somehow disclosure still happens, which is always super puzzling. And it comes with very significant consequences. So I beg and threaten everyone on my team when it comes to disclosure and being very careful not to bring things out of our data room. We've actually structured all of our files, so it's almost impossible to do it by accident. But you know, things can happen, but you should at least like be vigilant to try to avoid it occurring. So, but this is where you would start if you were trying to get access to the contextual data. It has all of the steps laid out for you here. And all of these links go to different pages that provide additional information. I think it is really important that either you or a major member of your team goes through all parts of the application process. Because the other thing I think that happens sometimes when people's applications don't get approved right away is that they miss a step, basically. And I think for enclave access, you still have to like send in a notarized signature or something. So it's like another kind of thing you have to plan into the time frame. Okay, so if there aren't more questions about the HRS, I'll move on to the Understanding America study. This is another study that has all the information on their website. The UAS talks about their data use in terms of tiers. So the tier 1 data user agreement is like for any data you want to use. If you want to use any survey data from UAS, you have to have that basic tier 1 agreement. So that gives you access to all of the public use products. Then they also have sensitive data that they call tier 2. And tier 3 is the restricted data, and it's the restricted data tier 3 products where you'll find any of the contextual data. So you're basically signing like different data use agreements, and the UAS data use agreement is really similar in spirit to what you would find with HRS. So you can go through these links to, if you're starting from scratch, then you need to start at tier 1. Maybe it turns out you want some of the sensitive products, go into tier 2, and then you do tier 3. You can't go like straight for tier 3. I'm like just absolutely fascinated. They strive to respond to your request within 3 business days. I believe it. UAS is on top of it. I should say for those of you who don't know, the Understanding America study is a study of adults 18 and older. So you could get kind of like a full age range that you wouldn't be able to get with our other studies of aging. This is a nationally representative study. It also does an oversample of folks in Los Angeles. It's a tablet-based study. It's also a high frequency study. So people are filling out these surveys like every 2 weeks. So you could imagine like some questions, you might really want to have that kind of periodicity that you wouldn't get with the HRS, for instance, because that's a study every 2 years. But if you're looking at things like progression to Alzheimer's, dementia, I don't know if you need every 2 week study. You could probably get away with these other studies. On the other hand, if you're trying to understand like stress variations with environmental stimuli, maybe an every 2 week study would be good for you. Okay, so I just want to show, are there questions in the chat or no? I want to show you their website. It's getting confused with escape. Okay, so so they hold their data in the linkage enclave, which is NIA's enclave. So a lot of studies will be putting their data in the linkage enclave. So they're using the protocols of the linkage enclave, which will vary a little bit from the MICTA enclave, but still not like really different. So after you set up your user account, you're going to have an electronic or a paper data use agreement. You can sign it on paper, but it's still going to have to be submitted electronically. They require that you have an IRB approval. So this one's a little bit different than the HRS process. You have to submit your CD, although that's kind of similar to some of the HRS process. And they basically just give you these different fields to fill in. But it's really similar. You're going to provide a description of your research product. You have to justify why the other data are not sufficient. So you really need to say like, well, this is a question about the environment, so I need tier 3 data access. This part I think is a little different. So whereas in HRS, they're like, you can click, you're busy, you don't have time to think about it. UAS, you actually really need to think about which data files you're going to need, but you can work with the UAS team as well. They have a nice help desk in case you have questions. And they just have like some additional questions that you won't necessarily find in the HRS file, which is that they want to know how you're going to disseminate findings. They want an estimation of the completion date, and they're saying that it needs to be within 24 months. Again, these are like the linkage enclave requirements plus some UAS requirements on top of it. And then they will ask you about like your software needs, whereas like the MICTA enclave has basically all the software that any of us would want to use. Okay, so that's the UAS, but as I told you, there's also this GLR. The MICTA enclave is super similar to the HRS enclave because they're all built on the same ISR enclave infrastructure. So the only reason that you might want to look at what MICTA has is because they also will link to PSID and the NHAT. So if you're not using the HRS, that's fine. These data products are available for these two other studies that are held in the enclave at MICTA as well. And that's anything in my contextual data resource, that state policies, and also a lot of the NANDA files are available here as well. But one of the things that they make clear is that when you apply, where is it? Oh, these are the current holdings. So this is the NANDA, my CDR, the state policies. Oh, and they put the long-term care focus data on there separately. It's been updated on the HRS website. Okay, but just so you see, when you go to MICTA and you're like, yeah, excellent, I want these data, they're gonna redirect you back to the studies because MICTA is not, MICTA doesn't have any rights to like approve your access to the study's data. They're just creating the repository for you in case one of those data products is not available in one of the study's own contextual data linkages, then you'll have access to anything from the MICTA's GLR, but you still have to apply through each study. So I showed you HRS, and then they're also telling you you would have to apply for PSID data through PSID, and you would have to apply for NHATS data through NHATS. Because these are all held in the same place, their data applications are actually pretty similar because like I said, HRS's data application is actually the Institute for Social Research computing team telling them what they would ask for people in order to get access to that virtual data infrastructure. So it'll be the same thing for PSID and for NHATS as well. The last route I told you about was the sort of individual linkages that we do with studies. For those, people just need to contact me and we need to figure out whether or not we can help people with the linkages. Sometimes we can't, but often we can, or we can at least help with some version of linkages. So if you work with a different data set that I haven't even talked about today, but it's a longitudinal study of aging, and your PI is interested in doing some data linkages, please feel free to reach out.
Our first speaker is Eunyoung Chae. She is a postdoctoral associate at the USC Leonard Davis School of Gerontology. She earned her PhD in gerontology from USC in 2022 and subsequently completed postdoctoral training at the School of Global Public Health at New York University before joining us here at USC. Dr. Chae specializes in examining the impact of environmental factors on cognitive health disparities among older adults, incorporating biopsychosocial approaches into ADRD research. Her most recent work aims to elucidate how climate hazards affect ADRD risks, with a particular focus on identifying specific psychosocial vulnerability and resilience factors. So please welcome me.
Hi everyone, my name is Eunyoung Chae. I am a postdoctoral associate here working with Dr. Jennifer Eichheimer. And my focus has been exploring the climate change related environmental stressors on biological aging and subsequent cognitive decline. I am so happy to share some of my work on the extreme heat and epigenetic aging acceleration here today. So I'm welcome any questions at the end of the presentation. Okay, So just to give a little bit of a background or motivation for this project, we all aware of or experience increasing frequency, intensity, and duration of extreme heat around the world. And in fact, 2023, the global mean is the third highest on the record. And extreme heat has particularly struck Europe, North Africa, and Middle East and Asia, and it caused many heat-related deaths. And the United States is not the exception. Extreme temperature events are increasing rapidly in the United States in the past few decades, and now are projected to affect over 100 million Americans by 2050. So why that matters? It's particularly concerning because heat exposure has been related to adverse health impacts across the different outcomes. So some of its direct impacts include heat illnesses such as heat stroke and accelerated death and hospitalization. But also it affects health through the indirect pathways, including the impact of health services and increased risk of accidents, and some of the increased transmission of food or waterborne related diseases. And it's particularly concerning for older adult population because of their age-related thermoregulatory function declines. So while we have some great evidence on the association between heat exposure and clinical outcomes, we still not really sure what's happening on our body at the biological level when we expose to heat. But the understanding the biological aging as an outcome is extremely important because it can inform the underlying biological processes that linking the heat and the clinical outcomes, but also it can serve as a precursor of subsequent disease and disability. In fact, many meta-analyses on the heat and cardiovascular disease oftentimes produce no findings, but it doesn't mean that heat doesn't have any impact on our body. It can just be it's still at the biological level, but then subsequently it can reach to it can manifest as a clinical outcomes. And for this study, we particularly focus on epigenetic as a potential biological mechanism linking heat and increased disease and mortality risk. So DNA methylation is one of the well understood epigenetic marker, and it refers to chemical change to the CPG sites on the DNA strand. Why that is important? DNA methylation is known to be very responsive to environmental stimuli such as heat or other environmental stressors, and also modulate gene expression so that thereby they can have downstream impacts on our health. And here we use the epigenetic age, which is the composite metric based on the DNA methylation levels across the CPG sites throughout the genome. So looking at the epigenetic age really provides a unique lens to pinpoint the system level biological responses to heat exposure. And here I adopted it from the prior study about the conceptualization or the hypothesis we have here. So if you look at the x-axis, it represents the chronological age, and y-axis is epigenetic age here. And then the orange line represents the high exposure to extreme heat. And as we can see here, we hypothesize that when you're exposed to high levels of extreme heat, you would have faster epigenetic age compared to your chronological age. But this idea of heat and epigenetic is not a new concept. Actually, many animal and human cell studies produced decent evidence indicating the maladaptive epigenetic changes in response to intense heat stress, but we know very little about what's happening in human populations. And among the first study that actually investigated the association between heat and in the human population is coming from the SCORA study, Cooperative Health Research in the region of Oxford. And they included 3,500 older adult participants in city of Asperg in Germany. What they found was that exposures to high temperatures are associated with increased epigenetic age acceleration measures, although the magnitude was different depending on what epigenetic measures they used, but it ranged from 0.24 to 11 years of epigenetic age acceleration. So that means there are some initial evidence that exposure to high heat may accelerate epigenetic aging in the human populations, but we need a strong evidence using the nationally representative sample of older adults, because prior study only used the single city center in Germany. Okay, so this shows the conceptual framework of our study. So we examined the heat and epigenetic aging in the US older adults. Our extreme heat data is coming from the contextual data resource that we are using. And then what we did is to conceptualize the extreme heat, we used the number of heat days at different level, caution and extreme caution and danger level. I will explain it in more detail in the coming slide. And then what we did is we calculated this number of heat days at the census tract level using the daily temperature, daily heat index data from the originally sourced from the GridMed data repository. And then for epigenetic clocks, we used the data from the 2016 Health and Retirement Study, Venous Blood Study, for whom DNA methylation was measured. So our analytic sample includes adults aged 50 and older, which is about 3,400. So how do we measure extreme heat exposure? Heat index is a measure of how hot our body actually feels. So it incorporates information not only from the air temperature, but also the relative humidity. This is because higher levels of moisture makes it much more harder for bodies to cool down. So this diagram shows, we adopted from the National Weather Service. It shows the different levels of the kind of cutoff that how the heat can actually impact our body. So for example, at the caution level, I forgot that I have the picture here. So at the caution level, our body possibly feel fatigue. And then extreme caution level, there might be a sunstroke or muscle cramps. And if we get to the danger level, it's likely that our body have sunstroke, muscle cramps. And then at the extreme danger level, it's very likely that our body will feel the heat stroke or sunstroke. So let me give you some example. So at the 80 Fahrenheit in the air temperature, one can be in the caution at 40% humidity here, but shifts to the extreme caution level at the 70% humidity and easily get to the danger level at the 90% humidity. So it really shows that we have to consider this both climate metric of air temperature and relative humidity. And the caution level heat index includes the 80 Fahrenheit and 90 Fahrenheit, and the extreme caution level it ranges from 90 to 103, and danger level 103 to 125. Also, there's another important aspect regarding the measuring the extreme heat exposure, which is timing. So we use the daily data so that we can really get into this short-term exposure, mid-term exposure, and long-term exposure concept. So what we did is the venous blood collected in the HS in either 2016 or 2017. And then for each participant's blood collection day, which is 0 day, we took the heat index value of that day and then categorize whether that is considered as extreme heat day at the caution level or extreme caution level, etc. And then another short-term exposure to kind of measures possible lag effects. We also we also take into account the lagged 7 days prior to the blood collection. So those two are our metric for the short-term exposure. And for the mid-term exposure, we considered lagged 30 days and then lagged 6 days exposure window. Finally, for the long-term exposure, we took the lagged 365 days, which is about an year. And then we also get into this cumulative exposure using the data availability we have. So our baseline here was 2010, and the reason behind the selection is more than 30% of our sample actually entered the HRS in 2010. So that we can have sufficient sample size. So that's why we selected 2010 as a baseline. And then outcomes for epigenetic age, we included 5 epigenetic clocks. So Hobbes and Hannum are considered as the first generation, and they were trained on the chronological age. And the pheno age and Grimm age are the second generation, and they were trained on the levels of actual biomarkers, just compared to just using the chronological age. And the Dunedin and Pace is third generation, and they were trained on the on changes on biomarkers with the chronological age. So this third generation really get into the concept of pace of aging compared to the levels of epigenetic aging. And to measure the epigenetic age acceleration, we calculated for each first and second measure by taking the residual from regressing epigenetic age on chronological age. So the higher value represent this person have accelerated epigenetic age compared to their chronological age. And we used the multi-level mixed effect linear model where individuals nested within the census tract because census tract would have the same value for the heat index. And we also calculated the intra-class correlation coefficients, which shows that there are a decent amount of the clustering at the census tract level that explains the total variance on our epigenetic age outcomes. Finally, for the covariates, we included the cell types, demographic, socioeconomic, and health and regional variables based on the prior literature on the health, heat and health outcomes. So this, now getting to the exciting part. So this shows the distributions of extreme heat data, extreme heat days across the United States. So this is an annual average number of heat days at the caution level or higher using the data from the 2010 and 2016. And this is before merging it with the HR sample. So this is across the United States. And then we use the quintile value, and the top quintile represent the census tract with the most extreme heat days, while the yellow, which is the bottom quintile, represent the tracts with the lowest heat days. But importantly, we see that there is some concentration in the southern part and western part of the United States. But when I looked at the data, there are also some heat days even for the northern part or the northeast part of the United States. So it's not like they have 0 days of extreme heat. And this shows the distributions of extreme heat days in our sample. And I will walk through the graph here. So x-axis shows the mean number of heat days in our sample. And then y-axis shows the different time window. And for 0 day, which is the blood collection day, because it's only 1 day, I categorize it whether they are heat day at the caution level or extreme caution level or danger level. So what this 44% represent here is in our sample, 44% actually on the day of their blood collected was considered as a heat day at the caution level. And then 90% of the blood collection dates among our sample were considered as extreme caution level heat day. And then there are only 2% that of the blood collection days in our sample that were considered. And then the 7 day, 30 day, 60 day, these are actually shows the mean number of heat days So we can interpret that on average, people experience 3 extreme heat day at the caution level over the 7-day window, and then 2 days at the extreme caution level over the 7-day window. But then by looking at this descriptive graph, we decided that just focusing on the caution level and extreme caution level, because there are very little distribution of the danger level of extreme heat, that wouldn't allow the sufficient further analysis. And now it shows the main findings. So it shows the extreme heat days and then epigenetic age acceleration. What you see from the y-axis here is Horvath acceleration on the left side and then Hannam acceleration on the right side. And the x-axis represents different time window. So on the blood collection day, if someone has the blood collection day was considered as a caution level heat day, then there are significant association about 0.6 acceleration in Hobart age metric. And then for the 7 days, I made a 7-day, 30-day, 6-day as a proportional just to make every metric as a comparable to each other. So that 7 days, it also shows that if there are many days were exposed to caution level, then they would have accelerated Hobart age. And the same thing for the Hannam age. So the bottom line here is there are significant association for the short-term measure of extreme heat and accelerated epigenetic age. And when we look at the extreme caution level, which is more severe heat condition, we see that there are a little bit of greater magnitude of the association from blood collection days, 7 days, and 30 days. And then, for example, 30 days window was only significant for the extreme caution level for Hobart acceleration. And when we look at the pheno age acceleration, we see that consistent and robust association between the heat exposure to pheno age acceleration, regardless of the time frame that we consider. And then actually, if we have more chronic, which is a long-term exposure, which is 365 days, or cumulative exposure, there were more accelerated pheno age outcomes. And finally, when we look at the Grimm age and Dunedin Peace age, we see kind of different story from the Hannam and Hobart's. What we see here is there are acceleration in Grimm age and Dunedin Peace age only for the longer term exposures. And then we don't see any significant association for the short term or mid-term exposure. So that was a lot of information. So I will summarize the findings. So this really provides some evidence that additional heat day may be associated with higher accelerated epigenetic aging using a nationally representative sample of overloads. And then it seems like a greater intense heat exposure matter more. And we found that although both acute and chronic exposure associated with epigenetic age acceleration, but importantly, differently across the clocks. So one of the possible explanation about why we see different association depending on the clocks, maybe this idea that the pathways of epigenetic aging captured in each of the clocks may differ. So prior studies showed that temperature increases are associated with DNA methylation of immune and inflammation related genes. And at the same time, another study found that these pheno age, Hobart age, and Hannam age only share very little CPG sites in common, meaning that they are getting different CPG sites depending on what epigenetic age measure we use. So they may be, one possibility is that pheno age may more get into this immune or inflammation related CPG sites compared to others. But there definitely should be more research like dissecting why we see the different association depending on what epigenetic measures we use. And another future directions that we are considering is this concept of resilience and vulnerability in response to heat exposure, because there are great population heterogeneity about how we deal with the heat exposure. And we tried exploring the independent interaction term, like the interaction term between the race, ethnicity, and heat measure, but we couldn't really find any meaningful interaction effects. So it may be the fact that the combination of multiple factors, like being Asian and having low economic resources and living in poor neighborhood with lack of cooling centers or green space, all these come together shape this resilience or vulnerability, not just only the single factor determining the resilience or vulnerability in the population. So that's our future direction. And
Okay, next up for our second presentation, we're gonna hear again from Jennifer Alshire.
Okay, I'm gonna do, I think, a relatively shorter presentation. I feel like this stuff is a little less exciting than what I've been working on recently. But so we just had the science of ADRD last week, and I did not put this figure in the presentation because Mark Hayward was in the office, in the audience. I didn't want to get in trouble. But he's not here today, so I'm putting it on the slide. So there was a report that was done a few years ago by a group trying to identify all of the factors associated with dementia and cognitive decline. None of these things were particularly like groundbreaking or revelatory for social sciences, but for this group that had been so focused on really kind of like genetic and biological risk factors, this was a bit of a revelation. And so they're looking at risk factors from early life through midlife to later life. And I just want to point out that in their most recent iteration, they actually included air pollution, which ranks a little bit above diabetes. And in some of the work that they had done looking at population attributable fractions, it was a non-trivial amount of the dementia outcome that they were attributing to air pollution. In this entire figure, this is the only what we would consider to be environmental, although biologists would probably consider everything in this figure environment. But for our purpose, this is the only environmental attribute that's made it kind of onto that radar. Of course, we know that it's important. Much like Eunyoung, we work in a space where we try to understand the cell and animal models research on this so that we can really establish that these things are, there's a biologically plausible mechanism. So a lot of the work that had been done on air pollution in the aging brain was coming out of lab studies. And then there were a couple of studies that were done in Mexico City in dogs and in children that provided really compelling evidence that there was a link between high levels of air pollution exposure and the brain. Not a lot of work had been done in older adults, however. So just to give you some background on what this exposure is, this comes from one of our data sets in the CDR. This fine particulate matter is quite small, and so I always show people this diagram to give you a sense of how small it actually is and why it's so pernicious when we breathe it. One PM2.5 particle is shown here in the little pink balls. You can see that it's like a fraction of a fraction of a fraction of the size of a human strand of hair or a fine piece of beach sand. What's important to understand about PM2.5 though is that it's really ubiquitous in the air we breathe. So we're all breathing a lot of PM2.5 here in Southern California. I'm sorry, that means you might be breathing more than what you're accustomed to. It's emitted primarily from traffic and industrial sources, but like I said earlier, there's also industrial activity that occurs in rural areas that are engaged in agricultural activities. And PM2.5 is a particulate. It has a bunch of things in it. It consists of organic compounds, metals, and the composition of PM2.5 varies from place to place. Older adults and children are especially vulnerable to poor air quality. Older adults in particular, because they may have pre-existing cardiovascular issues or other respiratory issues. And if they don't have cardiovascular or respiratory disease, they may have some other underlying risk factors that make them particularly vulnerable. So as I said, there was some biological work that's been done that shows this link between air pollution and cognitive functioning. We already knew that inhaling air pollution could result in deposits of particles into the lungs. It can deposit into some of our organs and it can end up in circulation. So it can induce an inflammatory response. The most disturbing research that came out like 10 years ago, and which one of our colleagues in the building has shown, is that the air that we breathe through our nose, the olfactory system, is actually, turns out, semi-permeable barrier to the brain. So we think about something like a blood-brain barrier really protecting the brain. It turns out ultra-fine particulates can also transverse the blood-brain barrier, which is scary. But particles can actually get translocated from our nose right into the brain. So these lab-based and some human studies have shown increased neuroinflammation and cerebral vascular damage that would be consistent with cognitive issues. So as I said, there hadn't been a lot of research on older adults. Most of the research was on children and then some on just adults. So about 10 years ago, Eileen and I published this figure using data from the health and retirement study, where we showed that a score on a TICS, a cognitive function, like an MMSE score that ranged from 0 to 35, declined at higher quartiles at PM 2.5 until maybe seeing a threshold effect around here. Back then, when we published this paper, the EPA standard was actually right around here, so this made sense. There's a little uptick here, but this is not a statistically significant difference. It basically levels off. But this 4.5 to 9.9 is kind of interesting because the EPA, as I said earlier, just last month revised their standard to 10. So now this group is like the only group in the sort of not unhealthy part of the distribution. So I'm a sociologist and demographer by training, and the group that I was working in did not consist of other demographers, but we think a lot about underlying population heterogeneity. And of course, like not everyone in Beijing, China, or Mexico City, or some of the highly polluted cities in other parts of the world are just like getting sick and dropping dead. And of course, the health of Los Angeles residents is not the worst in terms of health in the nation. So I think there must be some kind of underlying population vulnerability. This speaks to some of the points a few of you have been making about the new attempts to use machine learning to try to understand these vulnerabilities. I came at this from a very kind of theoretical perspective, thinking about how the aging brain is vulnerable to stress. Actually, this brain is the target organ for stress. So the chronic stress that people experience that's been associated with neuronal damage and decreased performance on cognitive tests that's been shown in a lot of different age groups might exacerbate the effects of inhaled particulate matter. And so I proposed that maybe neighborhood stressors would exacerbate the effect of air pollution in the residential environment. We just made this kind of figure to think about how air pollution might impact different health outcomes, that it would be modified by social environmental stressors. We didn't investigate these specific pathways, but we also hypothesized that psychological stress itself could create biological susceptibilities, which would have kind of an effect on health outcomes. And so we replicated, we showed something in an earlier paper, we replicated in the HRS. So this is a different year of data than what I just showed you, but it's the same kind of association where at higher levels of PM 2.5, we saw a decline in cognitive functioning scores. But we then stratified it depending on the level of neighborhood stress. And we define neighborhood stress in terms of neighborhood disorder, which is kind of a well-known concept used in the social sciences and neighborhood research to think about stressful neighborhoods. Another component of stressful neighborhoods might be neighborhood poverty or neighborhood deprivation, for instance. But this is really like signs of social disorganization, things that would engender a sense of not feeling safe or that look like signs of neglect. These have all been linked previously in the literature with worse physical and mental health outcomes in older adults. But there was only one study that had kind of tried to put neighborhood stressors together with air pollution in older adults. So we actually use both observed and perceived disorder. Perceived disorder comes from that psychosocial leave behind that the HRS administers to people and asks about, how people feel about their local area, the area within a 20-minute walk from their home. And it asks about standard measures like vandalism and graffiti and garbage or rubbish. This is America. Why does that say rubbish? And things like criminal activities. But in the health retirement study, because they have the interviewers out there anyway for those half samples that get the in-person interviews, they also ask the interviewers, what do you see when you're at the respondent's home? Do you see signs of vandalism, trash, boarded up houses, and things like that? So we created this variable, which was just for the observed disorder, if the interviewer noted anything that approximated disorder versus not observing anything. So the blue line now shows the relationship between cognitive functioning and PM 2.5 for those who live in a low disorder or low stress neighborhood. And you can see that this relationship is essentially flat. And that actually that relationship that I showed you previously in the full sample, where there was an inverse relationship between particulate matter and cognitive functioning, really we're only observing that in the high disorder group or people who live in a neighborhood that has some kind of neighborhood stressor. So this is actually very consistent with other work I've done with another colleague here in the room showing that like we would only find the relationship between PM 2.5 and cognitive functioning among the least educated folks, but not among college educated people. And this really, I think, belies this point that there is underlying population susceptibility or heterogeneity that we need to keep in mind, that even if you find a relationship, the relationship may be driven by people with specific characteristics, or in this case, by places with specific characteristics in the study. I also just want to point out that PM 2.5 is very spatially dependent. So we tend to find higher PM 2.5 concentrations in more densely populated urban areas. Now, technically, those are the areas where we locate air pollution monitors. So the federal government doesn't put monitors in places where people don't live. It tries to put monitors in places where there are populations and pollution. The data that we use incorporates satellite image data and some other sources, so it doesn't rely entirely on air pollution monitors. But I also want to point out that poverty and pollution tend to co-locate, although you typically only find it at smaller spatial scales. And in fact, if you don't go find enough in your spatial scale, you may not see the unequal burden of pollution in an area. I want to point out also that since the EPA started regulating particulate matter, which started around 1999-2000, the country's actually done quite a good job at reducing PM 2.5. So from 2000 to 2019, you can see there was a 43% decrease in the national average. We had an even larger decrease here in the LA area. So the EPA then lowered its standard from 15 to 12. So this is the new standard. And now, as I told you, they've lowered it to 10 again. So basically every time the country falls below the standard, it seems like the EPA is lowering the standard. That's not actually what's happening. They're just following the science. But I want to point out that there is persistent inequality, and the EPA itself has acknowledged that where air pollution monitors are might tell you that an area in general is doing okay, but it's missing these pockets of really poor air quality, which tend to occur in communities that have an overrepresentation of racial and ethnic minorities, and also communities that have fewer socioeconomic resources and less political capital to make changes in their community. When you're using this data, I want to just tell you a cautionary story that because the US has been so successful at reducing PM 2.5 concentrations and other criteria air pollutant concentrations over time, that if you look at the distribution of PM 2.5, for instance, linked to the health retirement study, you'll find in 2004, it looks like this red line here, it's a little bit flatter and the mean is around 12.4. But once we moved to 2014, just 10 years later, but with about 10 years of regulatory effort and response from local areas, that entire distribution not only shifts to the left, but it actually loses some variability. So the mean is lower in 2014, but the standard deviation is also lower. I'm telling you this because we have sometimes not found associations between PM 2.5 and health outcomes when we look at a later period, because very few older adults in the HRS are living in these high pollution environments anymore. Now, we're getting new cohorts into the HRS, this can always change. Also, the gains we made in terms of improving air quality, we seem to be reversing a little bit. We're not being entirely vigilant about what we're doing in the country. But to just keep in mind that the data that you'll have access to, you're going to want to examine some of the spatial variability, but you should also pay attention to the temporal variability as well. So I have some concluding thoughts. They're super similar to what Woon-Young talked to you about, probably because we talk about these things all day, every day. But so when you're thinking about the impact of physical environmental hazards on health, those may be important, but they may matter more under stressful conditions. I only looked at neighborhood level stressors. I could imagine people could look at other effect modification by lifetime stressors, experience of discrimination, interpersonal stressors. And so I think it's important to think about examining both social and physical exposures as well as their interaction. This you can do in a regression framework. It's not too hard. It's just interaction. If you want to do more interactions, and we have to abandon our traditional methods, but this works pretty well. I also think, there might be a lot of interactions with other environmental stressors like heat or green space or social deprivation. These are some of the areas that we're moving in with more sophisticated machine learning methods to try to get a handle on the multiple environmental exposures that people are experiencing. I also think, we're doing these like snapshots in time, and then sometimes we kind of predict things out into the future, but it would be good to measure this in a life course framework, which requires more longitudinal data and those complete residential histories that I was talking to you about. All right, so that's a quick presentation. Any questions?
I have, this is, one presentation. I just wondering, your last slides mentioned the total environment. So, this is a concept proposed by US EPA. And also in my field, there's also another concept, exposure. Could you comment, the differences between these two concepts?
Yeah, so the total environment framework is something the EPA came up with starting like 10 or 15 years ago when they realized that chemical exposures was not the sum total of all the exposures people were experiencing. So surprisingly, the EPA started funding projects focused on social environmental characteristics, the built environment, and other physical environment characteristics. Completely independent from that, the concept of the exposome developed, and this concept has been around for quite some time. I don't know whose field it belongs to, and I think a lot of people don't know what exactly it means. The only real difference between exposome and the EPA's total environment framework is that the exposome is talking about all of your social, economic, and physical experiences from birth all the way through life. Whereas the EPA is probably interested in life course, but they haven't theorized it quite the same way. And I don't think they're thinking about things like, how does your early life burden of social deprivation and stress maybe prime you to be more vulnerable to later life environmental hazards? So for me, that's kind of the difference between them. But yeah, I mean, we use exposome and total environment framework pretty interchangeably, depending on, what we're getting at. For me, the total environment framework is more of a modeling of how do we take all of a modeling approach for how we take all of our contextual data and try to put it into a multifaceted exposure model. Although, as was mentioned earlier, our traditional regression-based techniques are not going to get us very far, and that's why people have started trying other tools, basically, to accomplish that. But if you're really going to be doing the exposome, you really need to be looking at exposures over the life course, how they're impacting the underlying biology, and then leading to a later health outcome. So right now, exposome is an idea, the little pie in the sky. I think we have data. The reason you're seeing a lot of presentations from the HRS is because it's very rich biological data, really good phenotype data on like dementia, for instance, and it has a lot of good environmental exposures, and it has a lot of life course exposures. Do we have like the methodological tools yet to figure out how to put all that into a model and come up with some sensible answer? Not exactly, but I do think that that's probably where the field is moving. All right. We can switch to chat, yeah.
Okay, and then to finish us off, we have Chao Wu. Chao is a PhD candidate at the USC Leonard Davis School of Gerontology. His interest is in biodemography and population health. Chow uses large population surveys with biomarkers from multiple countries to understand health trajectories and outcomes. The biomarkers he uses include clinical markers such as cardiometabolic risk and cellular or molecular markers such as DNA methylation and RNA-based aging measures.
You can. Thank you so much. Good afternoon, everybody. My name is Chow. I'm very excited to be a presenter today. I'm going to present another project that we are currently working on based on the CDR data. I'm going to show the association between PM2.5 and epigenetic aging measures among a nationally representative sample of older Americans. But before I start, I would like to clarify that this title is not very accurate. I don't want to disappoint you at the end, so I would like to bring this up now that we only have null results. The associations are not statistically significant. It's always a bit challenging to present null findings, but in this case, I think null findings are very meaningful and important. I will talk about it soon. And this is a collaborative work. I want to thank my amazing collaborator, Jennifer Alsher, Onyang Choi, and Eric Kopak. So in this project, we care about air pollution and specifically PM2.5 because it links to health outcomes, including morbidity and mortality. Again, PM2.5 are particularly matters with a diameter of 2.5 micrometer or less. They are tiny, but because of that, they can get into our body very easily and potentially damage multiple organs and systems. As the diagram shows, they can impact the central nervous system, induce irritation, inflammation, and infection to the pulmonary system, and potentially lead to COPD and lung cancer. They can cause irritation of eyes, nose, and throat. They are also linked to cardiovascular diseases and have negative impact on reproductive systems. As an example, in 2019, air pollution continued to drive a significant burden of premature death and disease in 27 EU member states. Specifically, more than 300,000 premature deaths were attributed to chronic exposure to 5 particulate matters. Since PM2.5 is linked to many age-related diseases and conditions, it's reasonable to assume that it is associated with fundamental aging mechanism at the molecular level, like DNA methylation. Some previous studies did find an association between PM2.5 and DNA methylation-based epigenetic aging measures. For example, accelerated Horvath age and Dunedin pace. But as you can see, their samples have limited representativeness. That means we can potentially contribute to the literature by using the HRS CDR, for our sample is representative of community dwelling older Americans. So to summarize, since epigenetic gene regulation is one of the potential mechanisms linking pollution with increased disease and mortality risk, we would like to know whether PM2.5 is associated with accelerated epigenetic aging. The CDR is really valuable and helpful in terms of answering our research question. We can link multiple sources of data based on the geographic information of the HRS respondents. Specifically, we have 10 years of PM2.5 data from the US Environmental Protection Agency, which is available on the CDR website right now. We also have census tract level measures from the American Community Survey. And finally, we have individual level variables from the HRS that include social, behavioral, geographic, and the epigenetic information. To get the epigenetic aging measures, we use the 2016 DNA methylation sample, which is a random subsample of the HRS. And because of that, it has racial, ethnic, socioeconomic, and geographic diversity. And with survey weights, it is representative of the US older population. All respondents have geocoded residential addresses linked to the census tract. we use 5 epigenetic aging measures. Since Eun has did an amazing job introducing those measures, I won't go into the details, but basically we have first generation clocks including Horvath and Hannum age, second generation clocks including Grimm age and Pheno age, and we have the third generation measure that Needham pace. For the first 4 measures, we use the principal component and age acceleration versions. For the PM 2.5 measure, we also tried many different versions. The blood collection happened in 2016, and our long-term PM 2.5 measures are very straightforward. We just use the average of 1 year, 3 year, 5 year, and 10 year PM 2.5 levels, which are available on the CDR website. But sometimes DNA methylation can be really sensitive to exposures, and sometimes it might change right away. So we also made some short-term measures, including 7 days, 30 day, 90 day, and 180 day averages before the blood collection date. The daily PM 2.5 data are not yet available on the CDR website, but will be available soon. The construction of these short-term variables are a little bit more complicated than the long-term measures because we had to prepare them based on both geographic info and time info. Basically, we need to find the PM 2.5 value at a certain date of a certain place for each individual. And for both long-term and short-term measures, because people relocate over years, we use the HRS residential history file to make sure we use the location where people actually live. A little bit more information on the long-term and short-term measures. These are the distribution of PM 2.5 measures. We can see that there is greater variation across short-term distributions compared to long-term distributions. And also, the short-term distributions are more skewed. We have more relatively extreme values. In our model, we also have basic demographic characteristics, including age, sex, and race ethnicity. For socioeconomic factors, we have years of education, household income, and household wealth. Smoking is measured by pack year, which is a product of the average daily number of cigarette packs smoked and the lifetime years of smoking. So it is like a cumulative smoking history variable. We also control for track level information, including the percentage without high school degree and the median household income. Since DNA methylation can be very local, it means that methylation level could change a lot by cell type. We also control for distribution of immune cells. I think this is a fascinating part of using the HRS dataset because other than the epigenetic data, we also have the flow cytometry data of each respondent. So we can easily get the percentages of monocytes, natural killer cells, B cells, CD8 T cells, CD4 T cells, and the Eve CD8 T cells. Those are a pretty standard set of cells that we control for epigenetic analysis. Okay, so here is a correlation matrix, and it includes the epigenetic and PM 2.5 measures. We can see from the top left panel that epigenetic measures correlate with each other. And we can also see from the bottom right panel that PM 2.5 measures correlated with each other. However, the bottom left panel shows that the correlations between epigenetic and PM 2.5 measures are relatively weak. Most of them are less than 0.01. 0.1. And here are the multi-level linear mixed models for our main models. We have 5 figures here because we have 5 epigenetic aging measures as the outcomes. Within the figure, each row is a separate model using the PM 2.5 measure at the corresponding exposure interval to predict epigenetic age acceleration. All models control for all covariates, and as you can see, like I mentioned, none of the associations are significant. We actually have tried even more models than these. We also use several versions of dichotomous PM 2.5 measures. We dichotomized PM 2.5 based on the EPA high-risk cutoff, the top tertile, the top quartile, and top quintile within. Again, for each version, we tried all exposure intervals, but among the permutation of all models, only 180-day top tertile PM2.5 is significantly associated with the needed pace, and the coefficient is 0.01. It means that a top tertile PM2.5 compared to the lower values is associated with 0.01 more biological year per chronological year of aging. So it means it's associated with a faster pace of aging, but very, very slightly. And also, we don't feel comfortable enough to report that significant result when all the other models have null findings. So basically, we do not conclude a significant association between PM2.5 and epigenetic aging. And actually, the null findings seem to be pretty consistent with other existing studies as well. We mentioned this 2016 study in the beginning, where PM2.5 exposure was found to be associated with accelerated Horvath age. But authors declare in their paper that our findings are based on a cohort of older Caucasian males residing in a lightly polluted urban environment. Thus, studies including younger individuals, females, non-Caucasians, and in different environments are warranted to confirm our findings more broadly. There are also many other studies using different sources of PM2.5 data from different places and representing different population groups, finding no significant association between PM2.5 and various epigenetic measures. So the null findings are actually not that surprising. But then I guess the question is, there seems to be a reasonable theory and a pathway between PM2.5 and epigenetic aging. And some studies did find a significant result. Why are we different? So one possibility is PM2.5 does matter, but it's more complicated. Compared to the overall measure of PM2.5, maybe the PM2.5 species or the chemical components of PM2.5 are more relevant. The figures here are very small. They're not for you to read, but the point is the x-axis is the time and the y-axis is the regions in the US, and the colored little squares indicate the relative levels of the corresponding PM2.5 chemical components. It means that there is a big variation in spatial and temporal scales of those chemical components. So the pattern of the total PM2.5 may not reflect the pattern of the chemical components, which might be what really matters. One study based on normative aging study found that the lead and calcium components of PM2.5 are associated with accelerated phenol age. Another study based on the sister study also found that some clusters of PM2.5 components were associated with accelerated Horvath and phenol age. So one potential future direction is further examining the chemical components. Another very, very important point is we always need to keep in mind that when we measure the exposure, what are we actually measuring? One issue is that we measure outdoor concentrations of pollution at residence. The measure itself can come with some errors, but a bigger problem is that people leave their houses all the time. So we miss the exposure while commuting at the place of work and all the other places they go. Another issue is sometimes exposures may not show an association if they do not correlate well with the real biological responses. Our body clears a lot of what we are exposed to. It's like a self-protecting and a coping mechanism. Whatever is left over after the clearance is the biological uptake and can do real damage. But this clearance is for sure varies from individual to individual. So some people may have more real damage compared to others, even with the same level of exposure. So another potential future direction is we're thinking about use the exposure along with DNA methylation data to see if we can create these PEGs, which are the polyepigenetic scores or DNA methylation surrogates, to measure the biological uptake or the real damages. I think that would be a very cool way to use the CDR data in the future. And that's the end of my presentation. Thank you.
Thank you. This is a wonderful presentation. So actually, we have tried similar work. We look at, association between green space and epigenetic aging. So actually, we found a stronger association for those who live in more disadvantaged neighborhoods. So maybe you can stratify on this side.
Oh, that will be a very interesting assumption. And as Jennifer mentioned, we tested the modifying effect of or the interaction effect of neighborhood stressors in other projects as well. Maybe we can also try it in the current project.
Folks, we've tried everything. No one has ever beaten data down so hard as we did on this project. But the one thing we are trying that does seem to be working is that we're working with someone who's using neural net machine learning to try to get underlying vulnerable groups based on a combination of factors. That actually does seem if we can find the high risk people, that's the only time we find an association. But we spent 3 years trying to find something, and in that time, 3 more studies got published finding nothing. So we're thrilled to publish a massive no findings paper, submitting it very soon.
Can you elaborate more about the modeling that you use for the analysis? I'm assuming you used random effect mixed model. Can you elaborate more about like geographic clustering and everything that you used for the model?
So we use the census tract at the second level of model level modeling, and also we controlled for census tract level characteristics as well. Yeah, that's, I don't know whether that.
It was a longitudinal analysis, right? Or was it cross-sectional?
I think it's a cross-sectional analysis in this case.
So it was just a cross-sectional of association at the same time point between cognition and PM2 for air pollution. Am I correct?
Cognition?
Is it? No, not the cognition. I'm sorry.
The epigenetic aging measures.
Right. Yeah. Right. A cross-sectional at the same time, not the longitudinal analysis of change of the pollution, the effect of the pollution change on whatever your outcome measure was. Am I correct?
I think you're correct. So we are not trying to assessing the longitudinal association. We're just using using the average of a certain period of time, but still doing cross-sectional analysis.
But that this type of analysis, I think that's a certain limitation of the study because of its cross-sectional nature.
I see.
10 years of data is not exactly.
Well, it's not longitudinal. If it's not longitudinal, it's cross-sectional.
Well, so it's longitudinal pollution exposure, although not change because they all went down. So there wasn't enough variability to look at. There was no variation in change. They've all declined over time.
So was it longitudinal or not? Because even if it comes down, if you use mixed model to measure the change in over time, let's say it's been reduced over time, then you should see or not see, we don't know that. You should measure the change in your outcome. That would be longitudinal. But cross-sectional for this type of analysis, let's say 1 year of data, measuring pollution, measuring cognition. It just, I'm not sure what would it show.
So I have other papers that have looked at incident, cognitive decline, and cognitive impairment and dementia. This one is the outcome is epigenetic clocks. No one has longitudinal data on epigenetic clocks, not in older adults. So we can't do none of these papers have had longitudinal designs because the outcomes only measured at one point, these epigenetic clocks. The pollution measures are measured over time. But again, you don't know if these people moved in and out of their environments. This is sort of a limitation of these studies of not knowing where people have been, where they've come from. So that's a limitation of these studies without having that long history. And then Child's really underselling the massive amount of work he did. He did also look at regional differences, and we didn't really, because there was like, it's such a null association, no matter what we did. I think out of hundred something models, there was one model, it was a dichotomized PM 2.5 measure at one time frame on just the Dunedin accelerated age measure. So like, I just think that there's probably not an association there, which is pretty consistent with all of the other studies too.
Thank you.
Okay, since Eun just presented the association between heat and aging, did you try to adjust for heat?
Oh,
Yeah,
Oh, that-
you adjusted for temperature.
oh, yeah, but not in all the models. Yeah, but we adjust for temperature in some models, but the temperature itself didn't have a really significant association, and they didn't really change the result much. Yeah, basically we tried a lot of different combination of variables, but still really significant.
Another factor I was thinking is when I was looking at your model, I didn't see a matter of obesity because people have heavier body weight may inhale more pollutants to do just for BMI. I know it's a trouble measure in.
We also control for BMI in one iteration of all the models. We control it not only because it can potentially link to pollution, and also it can potentially link to epigenetic DNA methylation, but still it really didn't change the results. We also tried another like a set of sensor tract level variables like population density, because we also read that in the previous literature, but still all of them didn't work for us.
So just a follow-up question about that. So you mentioned that in the presentation, residential mobility is kind of controlled. I wonder if you just treat it as a control variable if someone has moved before, or did you really look deep into where they moved from, or for how many years, or where they lived from the history, life history, or it's just a control, how that was considered? Because I'm interested.
We didn't treat it, that's a good question. So we didn't treat it as a control. We just totally changed the location that in our data set. Like if they move from one place to another place before the move, they were considered as the residents of another place, another geographic, sensitive.
Okay, so that for someone who has moved several times, then their exposure is considered some kind of index? Or how did you measure the exposure then?
Oh, so we also get the exposure data from where they live. Yeah, so basically we change their geographic information if they move. So it's like in the data set, the variable itself is changed. It's not like adding a new variable as a control. That's a lot of work, I know.
Oh, but like if they were observed for 5 years in the HRS, their 5-year average was wherever they were. The problem is the people we don't have in the study, we don't know where they were. Which is a big black box problem that we have to address in these studies at some point.
It's not good at all. Okay. So my question is, previous presentations showed a high correlation between level poverty rate and air pollution. So in your study, you also control for census tract level like median household income. So if those variables highly correlated with the predictor, will that impact your estimation?
You mean controlling for it?
Yes, yes.
Before control versus after control, does it change anything?
So I'm asking why you're controlling for the census tract level variables like household income, median income, because previous presentations showed that a variable like poverty rate is highly correlated with PM 2.5. I mean, if they're highly correlated, you're gonna have a collinear problem. That
I
will throw
see.
off the estimation.
Okay, so to answer your question, there are two aspects of my answer. The first one is we for sure, we have to control for them because they are potential confounders. They are associated with exposure and also associated with the outcome. So in order to have a unbiased estimate, we have to control it in our model. And this second point is we try the correlation matrix and we run the test and for multicollinearity, and it indicates not a big concern of multicollinearity. So we still, and because they are potentially confounder, we still put them in the model.
Thank you.
Okay, Chao, this is coming from the Zoom chat from Liang. So they're saying very interesting study. Just a quick comment. I think if you also control for city level effects or effects at even broader geographic scales, maybe the outcomes might be different.
Try some regional, we tried control for the region that the respondent live in.
We did a random effect for MSA. We don't do cities because we don't have that data. But we did do a random effect on MSA. I cannot stress enough how null findings. Having said that, Eric Klopak helped us make pegs. Those actually are all associated. So it may also be that when we measure exposure at where someone lives, we're missing their exposure on commutes, their exposure at work, their exposure every other place they go. And we're missing like the actual biological damage that might happen because some people's bodies clear toxins better than others potentially. So if we get a more biologically informed exposure measure, we actually do see relationships. So, you know, we'll keep trying. Chao's still here for another 2 months before he leaves for his postdoc. He could run many models. All right, I think we're ready to move on. Thanks, Chao.
All right, now we are moving to the social environmental aspect of the CDR data set. And our first presenter is Margaret Courtney. She was an associate professor of sociology at the University of La Verne, where she conducted research on topics related to family, social determinants of health, and inequality. Her recent work focused on the social, political, economic, environmental, and biological factor effects on osteoporosis, like in the high sensitive R reactive protein and telomere length, and was funded by multiple PIR 15 award from the NIA. And she completed her PhD in sociology at the University of Michigan and a postdoc fellowship at the Harvard University. In June 2023, she transitioned to a role as a social science analyst at the U.S. Department of Housing and Urban Development.
All right, thank you, everybody. So this is a presentation about neighborhood SES and telomere length. Spoiler alert, also some null findings here. So as you mentioned, I am at HUD now, but this work was conducted when I was at the University of Laverne. None of this obviously reflects any positions of the Department of Housing and Urban Development. All right, so this is joint work that was published in 2022 with Josephine Roberts, who was our undergraduate research assistant, and my colleague on the NIA grant, Kanya Godi-Kristen. So I'll give a brief motivation, talk about the data sources and some of the data considerations, talk a little bit about the methods and results, and then give some discussion and conclusions. I didn't know what the other talks were exactly going to be about, but I think you're going to see that some of the conclusions I end up talking about relate well to some of the stuff we've heard so far. And that's the citation for the article if you're interested. All right, so the motivation for this piece comes about really based on literature, looking at the accumulating cost and weathering hypotheses and thinking about how exposures to a variety of social stressors over time could potentially cause damage to the body, including shortening telomeres. So we know from some prior research that prolonged exposures to a variety of kinds of social stressors, like environmental, economic, and so forth, might increase inflammation and lead to physiologic changes, and shorter telomeres are one possible outcome. There are conceptual models of the social determinants of health for chronic inflammation and potentially telomere length. I'm going to show you the example we used in the paper. This is derived from models from Donald Barr, Kubzansky et al., Riancho and Brennan Olson, and a prior paper that we did as well. So on the left-hand side, I know it's a little tiny, but on the left-hand side, you have all these different kinds of exposures. So this is just giving you a few. I'll talk more about why it's not all of them in a minute. But you can think about health and psychological factors. You can think about contextual and environmental factors, as people have been talking about already. You can think about demographics, economics, political context, and so forth. These pieces can potentially, exposure to lots of these stressors, can potentially lead to immediate stress responses, and for some people, a chronic stress response. That chronic stress response then can lead to an increase in stress hormones like cortisol, an increase in inflammatory biomarkers like C-reactive protein, which is linked to widespread inflammation in cells. And there's a theoretical reason to think this might be then related to what happens to DNA and how telomeres may become shorter. Socioeconomic position down here is kind of influencing the risk factors on the left, those exposures, also the chronic stress response. So after we do a very extensive variable selection process, which I'll talk about more in a little while, we find that only 3 of the domains we initially started looking at were relevant to or seemed to have a correlation with telomere length. So some of these health and psychosocial factors, contextual environmental factors. So by contextual here, we're talking about things like the percent of the population in poverty. And then some demographic factors. And so I'm going to go through, when I talk about the methods, I'm going to really focus in on the contextual factors, but I'm happy to talk more in Q&A about other variables that we included as well. So I'm focusing mostly on the neighborhood characteristics. All right, so the data sources. So we use the health and retirement study. We started with the longitudinal file, but because we're looking at telomeres, which are from 2008, we limit the data to 2008. We have the cross-wave race and ethnicity file, the psychosocial and lifestyle questionnaire, the biomarker study, and the telomere study. We use 2 components of the CDR, the American Community Survey data and the EPA air pollution data. And then we also were allowed by HRS to merge in data from the Correlates of State Policy Project database. And I'm not really going to talk about that today, but if anyone's interested, you can certainly email me. And I have my email at the end. So there are a few considerations we had to think about when we were thinking about what to do with the data. First is, what do we do with telomere length? So some studies use it as a continuous measure. Some studies dichotomize it. Some studies say anything above the number 2 is probably inaccurate, so you should cut it off at 2. So we went through a lot of studies and ultimately decided on following Petterman et al. In terms of dropping the values greater than 2. And then we dichotomized telomere length so that the shortest 25% were coded as 1 for short, and everything else was coded as 0 for normal. We did also look at continuous measures of telomere length, but it doesn't end up really changing the outcomes here in terms of the linkages or lack thereof with these variables. All right, so the second consideration that was really big for us was which of the many potential variables should we include in these models? So as I mentioned a little while ago, we ended up focusing on health and psychosocial factors and environmental and a couple other things, but we also looked at a wide range of economic factors, political context, policy, healthcare environment, like all kinds of things as well. And so what we did to narrow down is my colleague, Kanya Godi, is a biological anthropologist, and she is really into using variable selection methods starting with Spearman correlations and then using change in estimate variable selection. So that's ultimately what we ended up doing to winnow down the variables. And with the change in estimate method, if you're not familiar with it, you have an anchor variable, and then you're looking to see how that coefficient changes when you add different variables, because it indicates confounding. And so in the Logit model, we do the anchor variable is age, and in the Cox model, we do the anchor variable is sex. So in the CDR data with the ACS, we have state level percent identifying as Hispanic or Latino. We have a variety of county level data, including percent non-Hispanic white, percent age 25 plus without a high school degree, population density per square mile, percent in poverty, and the percent with a high school diploma. Then from the EPA derived data, we have mean NO2, mean ozone, and mean PM2.5. These all came out as potential predictors of telomere length after we did variable selection. All right, so first we did logistic regression. The contextual variables in these models are the percent non-Hispanic white in the county, mean NO2 for September, mean ozone for April, May, and November. Feel free to ask questions later about why we're using monthly data for the pollution, but we would probably do some things differently if we were redoing the paper now. We have 4 models. Because there was that hypothesized inflammation component, right? Our models 2 and 3 include high sensitivity C-reactive protein as a measure to see if that is if that's a mediator between these exposures and telomere length. It's not going to turn out to be the case. And then the 4th model just includes the significant predictors following an approach for unbiased odds ratios. All right, and then we have Cox proportional hazard models. And this set of models has a few more of these CDR variables, including the high school degree data, the percent in poverty, and the mean ozone on a quarterly basis, and mean PM2.5. One thing I'll just note, because someone might ask this question, the percent that's age 25 and higher without a high school degree and the percent with a high school diploma, those 2 variables are actually not correlated enough that you can't put them in the same model and it all comes out fine. The collinearity is very low. Okay, so what did we find? So in our logistic regression models, I'm just going to focus on the last one. What we found is that certain things were related to shorter telomere length, but not the contextual variables. So age, for example, older age, higher likelihood of having shorter telomeres. This is not surprising. Having ever smoked, higher likelihood of shorter telomeres. Having more nights spent in the hospital, and having a higher index or a higher score on the index of lifetime traumas before age 18. All of those were linked to higher odds of short telomeres. On the flip side, female sex, identifying as Black or African American, and having seen a dentist in the last 2 years were all linked with lower odds of having short telomeres. So this is the logistic regression results. In the Cox proportional hazard measure, you can see some other things were significant here. So the pieces that are linked to short telomeres are having a GED or high school graduation compared to less than high school. This is interesting. I'll come back to it later. And your weight in kilograms. Things that were linked to lower hazard of short telomeres were having Medicare coverage, having seen a dentist in the last 2 years again, and then kind of interestingly, and we don't really know what to make of this one, saying that you have a little difficulty walking a block versus having no difficulty. We sort of have a hypothesis here, but we're not entirely sure what to make of that result. So even though going through variable selection, it seemed like a lot of these contextual variables from the CDR would be really important predictors of telomere length, and including all the ones listed here and the things that I talked about before. None of these were significant when we included other predictors like demographic factors and things like that. So it looks to us like it looked to us at the time like they were confounders. I'm going to talk a little bit more about how I think we could go differently in the future in a minute. So we found no evidence for the conceptual model in figure 1. We really didn't find that like these exposures seem to be linked to inflammation, which is then linked to telomere length. Like we weren't finding that here. The results for demographic factors are pretty consistent with the prior literature. So being female is related to longer telomere length in literature, as is identifying as Black or African American. Education, so I said it was kind of odd, right? Because the people with GED or high school seem to have sort of like worse outcomes in a sense than the people with less than high school. But then the people with more education don't look different, right? In prior literature, it turns out that education is it's a mess, right? Like some studies are like, yeah, education linked to longer telomeres. Other studies are like, education linked to shorter telomeres. Others like, education doesn't matter. So it's not terribly surprising maybe then that we found that like the results are kind of not consistent, right? Because prior literature has not shown a consistent relationship with education. For the health-related determinants, our results confirm prior research that people who have a history of smoking seem to have higher odds of having short telomeres. And the link posited in the literature is really that tobacco is just really bad for your DNA. Shorter telomeres in respondents with more overnight hotel or hospital stays, not hotels, we think is probably related to underlying frailty. And the dentist result, we were kind of pondering for a while. But one of the things that we found in some of the prior literature is that people who regularly go to the dentist seem to have less chronic inflammation, probably in part related to lower levels of periodontal disease. That's kind of like hypothesized in some of the literature. And so chronic inflammation is something that, although we didn't find a link with CRP in this study, it's something that has certainly come up in the literature before, that chronic inflammation is not great for telomeres. None of the environmental or contextual factors that we tested were significant predictors. Air pollution seems to be a confounder. But the prior literature on air pollution and telomeres is pretty narrowly defined in terms of like the linkage, so maybe not all that surprising. Okay, so we kind of concluded that confounding seems to be pretty widespread. A lot of the variables seem to be confounders. And that telomere length was robust to the effects of a lot of social determinants. But I think I was like thinking about this, but didn't put it on the slide. And now that everybody else has also kind of mentioned it. So I think if we did this study again, one of the things that we would do differently is try to come up with more of like an index of the exposure. Because having all of these disparate pieces, at the time we were kind of thinking like, well, okay, this sort of makes sense because these things could operate in different ways on people's bodies and stuff, but it's probably not that living in a high poverty neighborhood doesn't matter at all, right? It's probably that there's like a broader context that links a number of different things together, like maybe living in a population dense area with high pollution that also has a lot of poverty, that also has whatever else, right? That like a lot of these things together may be related to people's telomere length, and maybe not. But that's something that we didn't actually do in the study. We didn't try and come up with some kind of like index or score or something like that. And that's something I think we would do differently in the future. And kind of like, and that seems to link to a lot of these other talks that we've just heard about how trying to combine the factors together seems like a useful approach for the future. So I'm happy to take questions. If you want to email me to ask me about any of the data sources or link to the paper or whatever, my email address is up there. Feel free to email me. And yeah, questions.
Yeah, well, Preeti put some comments in our chat. So she had asked why seeing a dentist in the past 2 years would be associated with lower telomere. And then also mentioned that the finding that women have shorter telomeres, that women are living longer than men. So it's interesting that they would have.
Oh, no, women have longer. They have a reduced odds of having short telomeres. Yeah, so theirs are longer. Yeah, and the same with the dentist. So if you said you went to the dentist within the last couple of years, you're less likely to have short telomeres. You know, and really, like I said, we're sort of speculating here, right? About why that could be. But we do know that poor dental hygiene and periodontal disease and things like that are associated with chronic inflammation and a lot of health problems that go way beyond what's going on in your mouth. And so we're sort of speculating that maybe if you go to the dentist more regularly, some of those problems kind of get addressed before they get bad and before they really harm your health. Yeah.
So it's funny, like with education, like we're hearing about it a lot. There were like trainings around like the connection between cognitive decline and education. And like my question is, what are you thinking about education and what you're seeing in the literature and think about like what education represents? What could it really be? What should we be looking at instead that maybe education, it might be a proxy for, but we're just kind of missing the mark?
Yeah, so with telomere length, I'm not 100% sure. So some of our other work, a lot of our other work in this grant was on osteoporosis, and we find some more evidence for education and in the direction you would kind of expect, like more education seems to be linked with lower odds to some extent. But what we think it is in that case is really more about kind of access to knowledge and access to resources, right? So in our osteoporosis work, one of the things that we find is that it's very underdiagnosed for people who identify as racial or ethnic minorities, who have low resources, things like that. And so part of the being able to report a diagnosis is that you actually saw a doctor who would test you, right? And so the people who have more education seem to maybe be more likely to get the diagnosis, probably because they go and they're like, hey, I'm worried about this, right? And then their doctor says, yeah, sure, let's test you. So I think in some cases, like in some of our work, it seems like it may be a proxy for like kind of linking to resources or being able to leverage your position when you're dealing with healthcare providers. Not so sure that that really fits with the telomere length part. So I'm not entirely sure about that. Yeah. And the prior literature is very mixed, it seems like, with regard to education in terms of like what they find.
Yeah, so I'm just, as I'm thinking about it, if we're like taking the approach with like osteoporosis and it being your access to care, are there other things to look at, like type of insurance, whether it's employee sponsored or public, and like if all those things are kind of moving in the same direction? But you're right, with telomeres, it's like, I feel like we're thinking about, is it exposure to like chronic stress, like all these different things that we don't really capture in these surveys.
Yeah, and that's absolutely something that we, like, for example, in one of our prior studies, again, it was with osteoporosis, but we did actually look at cortisol levels because we were using the MIDAS data for that. And that's something that we couldn't do with HRS, right? But like there might be something there, right, with that. There was something else you just mentioned that I'm now blanking on. Anyway, if I think of it, I'll get back to you. It was also about the osteoporosis. Oh, the insurance piece. And yes, we actually have a paper on that, and Medicare turns out to be plenty good for helping people get access to bone density scans, but Medicare plus private insurance is even better. So yeah, so there is certainly